think we'll get started. A few stragglers will probably come a little later. I'm Dr. Craig McCoy. I'm the president of the Crescent Foundation, Incorporated. I practice anesthesiology down in Bradenton at Lakewood Ranch Medical Center and Manatee Memorial Hospitals. Welcome and thank you for coming out to the H. Lee Moffitt Cancer Center for the Crescent Foundation, Incorporated's Colorectal Cancer Community Education Symposium. This symposium was made possible by grant funds from a competitive statewide community education grant program to address cancer disparity fiscal year 2009-2010 of the Florida Division of the American Cancer Society and an indivisible partnership with the Tampa alumni chapter of Phi Beta Sigma Fraternity Incorporated, an African American fraternity founded at Howard University on January 9, 1914. The Moffitt Cancer Center, Department of Diversity, and the University of South Florida College of Public Health. In 2005, the Tampa alumni chapter of Phi Beta Sigma founded the Crescent Foundation, the 501c3 section of the chapter. The mission of the foundation is to offer educational and social programs and activities to males 13 through 18 years of age, the fraternity's Sigma Beta Club, assisting them to excel in contemporary society by focusing on education, home and family, culture and society, athletics, and personal development towards a college education. Many of them are volunteering today here at our symposium. This year, in addition to mentoring youth, the Crescent Foundation Incorporated and the Tampa alumni chapter of the fraternity have embarked on promoting minority community wellness through education. And here we are with a health symposium designed to enlighten you with information for us all to make the right choice for our health with regards to colorectal cancer, prevention, screening, diagnosis, coping with cancer, and treatment. In the United States of America, there is a colorectal cancer disparity when it comes to incidence and death rate of African Americans compared to the majority population. More African Americans get colorectal cancer and die from it than the majority. Many reasons exist for this, including poverty, cultural and religious beliefs, myths, lack of access to health care, i.e. no insurance, unemployment, unaffordable, personal phobias of being examined, and the idea of poked and prodded during examinations with discomfort and while awake, genetic influences, racial and cultural biases, and perhaps many other reasons. Even though we can't change society's views on race, ethnicity, and culture, we can change to live a healthier lifestyle by eating healthier and exercising regularly, going to the primary care physician annually for a physical, getting screened at the appropriate age and time in your life, and if found, get treated early. More people survive early stage of colorectal cancer than later stages. At this time, I'd like to introduce to you Dr. B. Lee Green, Jr. He is the Vice President of Moffitt Diversity and Professor of Health Outcomes and Behavior at H. Lee Moffitt Cancer Center and Research Institute. Dr. Green received a joint PhD from the University of Alabama and the University of Alabama at Birmingham. Prior to joining Moffitt, he was an associate professor in the College of Education and Human Development of Texas A&M University. He was also the director of Texas A&M University Center for the Study of Health Disparities. His research interests focus on health promotion and disease prevention in the African American community, particularly minority participation in research studies. As a result of Dr. Green's work in the area of minority participation in research studies, he was invited to be a participant on the Tuskegee Syphilis Study Legacy Committee and was invited to the White House for a formal governmental apology. He serves on various national and regional advisory boards. Please welcome Dr. B. Lee Green.
I noticed Dr. McCoy left out a very important part of my introduction. I'm a member of Kappa Alpha Psi fraternity. So it's going to be hard for me to stand in front of this banner here. Is there a way we can move this while I'm talking?
It's streaming all over the world.
I know. That's okay. I'll survive. Good morning. I hope everybody's doing well. I'm obviously just delighted to be here. Delighted to see the young folks here as well. Any future oncologists, physicians, researchers? Yes? All right. Pharmacist, okay. Good. I'm glad you're here. I think the exposure to a place like Moffitt, other healthcare institutions certainly will hopefully give you that fire to get out there and join us in this research world. One of the things we do know is that we don't have enough black or minority physicians who are out there serving, particularly in minority communities. So I'm glad you're here. I just want to take a few minutes just to thank all of you for being here. I want to certainly welcome you on behalf of the leaders at Moffitt. Not only the leaders, the faculty, the staff, the physicians, all of the folks here at Moffitt who come here every single day to fight the fight against this incredible, terrible disease we call cancer. But there is hope. And I think that's why we show up every day, is because of that hope. You know, back in the day, you know, people heard the word cancer and they automatically thought what? What did they think? They thought death. Well, thank goodness that's not the way it is today. Certainly there are people who still hear the word and think that, but we have such incredible people here at the Cancer Center who are working every single day in the laboratories, in the clinical settings, trying to figure out how to beat this dreadful disease. I do want to also thank the Crescent Foundation, the members of Phi Beta Sigma for taking the leadership for events such as this. I think it's so critically important that we have community organizations who take on these types of topics, particularly because of what Dr. McCoy said about this whole issue of disparities. Disparities is a serious issue, and not just as it relates to cancer, but if you look at the top 10 diseases, African Americans in particular tend to die at a higher rate, tend to get those diseases at a higher rate, and we have to get something done about that. And I think we have a lot of people now who are working towards trying to address health disparities, but it's so important that we have these organizations out there who are also out front trying to get the word out. We obviously are hearing more and more about health disparities. It's just getting out there. I think people are realizing that it is a serious problem. But I always tell the story back in 1990 when I was I was working on my PhD and I had to come up with a topic of interest that I wanted to do my research on. I remember having a conversation with my major professor, and one of the things that I told him was that I was quite interested in this whole issue of minority health. That's what it was called back in the 90s, minority health. You know, we call it now health disparities. And I remember him looking at me and basically giving me a strange look like, you want to study minority health? What is wrong with you? You won't get anything published. You won't get any grants. You won't be invited to do presentations. He said you're going to basically kill your career. It's just not a wise career choice. Well, there's a long story behind that. But to make a long story short, obviously I didn't listen. I went ahead and decided to focus my efforts as it relates to minority health. And today we have NIH, who has an institute now that focuses on health disparities. You have NCI. Every single institute within NIH has some focus on health disparities. The interesting twist to this story, that same professor who told me that I would kill my career is now leading a major health disparities research center in some other state. And every time I see him at a major conference, he hates to see me because I always remind him of that conversation that we had back in the early 90s. So it's a major public health issue that we have to address. We at Moffitt, we can't address it alone. USF can't address it alone. We have to have these types of partnerships in order to get the word out, particularly to minority communities, that this is a serious issue. I often tell people how I even got into this in terms of my interest in minority health, and it was a personal issue. It was a personal story, aside from the fact that my NBA career didn't work out. I guess I was too short. That didn't work out, so I had to fall back on something else. But I got into it because of a personal situation with me. My grandmother, and those of you who know me, you know I tell the story every chance I get, because for me it's important to put a face on this thing we call health disparities. And the face for me is my grandmother. When I was growing up, I was probably 12, 13 years old, had a grandmother who suffered severely from diabetes, severely. She ended up being so bad off, she ended up having to move into our household. So 12, 13-year-old growing up with this woman who was, suffering from this disease. So she'd leave the house, go to the hospital, and they'd, cut off a toe. She'd come back, she'd heal, then she'd have to go back and they'd cut off a foot. And it got to the point where she ended up losing both of her limbs. And as a young kid, to see that on a day-to-day basis, having to be a part of her care, had a significant impact on me. And I always wondered, is there something that could be done so that we don't have other people who suffer like she suffered? A wonderful woman, she cooked incredibly well, and I think that was a part of the problem. And you'll hear a little bit about nutrition. How many of you grew up, and some of you are young, I know, with the 2 cans on your stove? The 2 cans, you know the cans I'm talking about. What are the 2 cans I'm talking about? The grease. One for what? One for fish and one for chicken. You couldn't mix them up. And I remember her going in there, scooping that lard up, putting it in the pan and using it in a lot of the dishes that she prepared. And it was one, and I was fortunate. The majority of the folks in my family are overweight. I got the skinny gene somehow. Thank goodness I got the skinny gene, because I was eating the same way. But somehow I didn't get affected by that. But that situation, that story, was the reason why I got into this whole issue of minority health, because it wasn't just my grandmother. It was a lot of people in our community who suffered severely, not just from diabetes, but from cancer, who died. And when I was growing up, they didn't even want you to say the word cancer. You remember that? You couldn't even say the word cancer. Didn't want to go and visit people in the hospital who had cancer. But thank goodness we have changed, and I think as a result of these types of partnerships, we are getting the word out that this thing can be beaten. And it can be beaten with education, with screenings, making sure that folks go and get their physical exams on a year-to-year basis. Before I sit down, I did want to put in a quick plug to the Center for Equal Health. It's a new NIH-funded health disparity center that is a joint partnership with University of South Florida as well as the Moffitt Cancer Center. And it's basically designed to build the infrastructure so that we can more properly address this whole issue of cancer health disparities. And I would encourage you to go out on the website. We have a web site that you can visit. It's called the centerforequalhealth.org, I think it is. But if you just want to put it in Google, you certainly can find it. But would love for you to visit the website. If you see something there that you're interested in, we'd love to hear from you. We'd love to build relationships, because we believe that that's the only way we can address this issue in its proper way. And then lastly, I want to thank all of the speakers, the ones from the community, from Moffitt, from USF, and all of you who had a hand in pulling this symposium together. Incredibly important that we do this as often as we possibly can. I wish this whole room was filled, and I think at some point we're going to get to the point with these continued partnerships where folks in the community are here and we don't have places to put them, standing room only. So I'm past my time. Thank you so much for being here today, and I want to reiterate, if there's anything that the Moffitt Cancer Center can do for you or the community, please don't hesitate to contact us. Thank you very much.
Thank you, Dr. Green. ACS video with Steve Harvey Morning Show. He has a lot of penetration into the African American community in the mornings.
talking about implementing the draft and upping the age. Tell you what, stay away from my age group.
I've been in this business since I was 28. I constantly tour. I got a syndicated radio show.
I'm gonna tell y'all something else about this radio show.
You know, I'm a father, I'm a husband, and I'm an author. I mean, if you break down what I do, I tell jokes for a living. But you know, this is serious. You know, I want to live. So they got a test that can prevent colon cancer. You gotta go get it done. It's not that big of a deal. I'm here to put my life on tape. Isn't this fun?
Oh, it is. I see this every day.
I'll be necking in a minute.
This is a medication list. If you're taking current medicines, write them here.
Okay. I have a secretary, though.
Okay. All right.
Pretty, ain't she?
Okay, yes,
Yeah.
she is.
Always
She is pretty.
bring your wife with you.
What procedure are you anticipating today?
An x-ray?
A colonoscopy.
Okay.
You did a full preparation. Tell me about your preparation.
I took the 2 pink pills at 11:30, and then around 1:30 when the activity started, and I started drinking the solution to half a gallon, and it was absolutely delicious.
Okay. And you've not had anything to eat or drink since last night, correct?
No, I haven't had a single morsel.
Good
Hey,
to meet
Dr.
you.
Christie, how you doing?
Good, good. How are you?
I'm fine, how are you doing?
Good to meet you.
I strongly suggest that you all get a female doctor, too. It's just-
A colonoscopy is a procedure in which we insert a thin, flexible rubber tube inside the rectum. It allows us to look at the lining of the colon. We can inspect the colon for polyps. A polyp is a growth that is pretty common in the colon. We think that most cancers develop from a polyp. So what we're going to see now is the image of the colon lining. This is not Mr. Harvey's colon, but it is the typical image that we see when we're looking inside the colon. According to the American Cancer Society guidelines, average risk individuals should start screening at age 50.
I waited till I'm 52. I'm 2 years in. So, I really should have got it done at 50. So I'm doing this, to get more people aware of it, and let you know, there's nothing to it. You got to get it done. I want to live. I want to see my grandkids. I have no grandkids. I want to see some. Women play a crucial role in this whole thing because, and there was a moment I was going to cancel the procedure. She said, oh, no, you're going. Wanting to live has got to be bigger than the fear of the procedure or the, oh, that's just an exit only. We only own nothing, go back. Okay, my man, but I tell you what, though. This is how it's done to secure your future, a future for your family and your kids.
We need him to stick around, so we need him to be healthy. When we do a colonoscopy, what we do is we use this wonderful instrument. This is called a colonoscope. It has a camera and a light on the tip of it. It's a thin, flexible tube, and images of the lining of the colon are displayed on a monitor. And during the procedure, we can look for polyps. We can put a wire around a polyp and burn it and snare it off at the same time.
They found 3 little polyps, they take them out right away. She assured me that it looked nothing, no cancer.
After the procedure is done, you don't need to come back for another 10 years.
With all the things I have at my disposal, I didn't know about it. And I think that people are going to have to do more to get the word out because our community does not know about it. You got to use unorthodox methods to get this word out here.
If we can detect colon cancer early, it is highly treatable, and patients have successful recovery from colon cancer treatment. And if colon cancer is detected too late, the outcomes are just not as good.
You get it done, you live. You don't get it done, you're taking a risk. Hey, listen, everybody, to get more life-saving cancer information, please go to www.cancer.org. Or, it's simple, you can make a phone call to the American Cancer Society at 1-800-227-2345. Do it today.
Wow, quite a serious message. Steve Harvey's made me laugh for many years on my commute to work, to residency. wherever I'm going in the early morning, and it's kind of a treat to see that he directs his energies at making something like this for the community awareness of colorectal cancer and preventing and beating this disease. Let's go on and move on with the program. We have a group of panelists here, and the first panelist is Catherine Allen. She is a registered dietitian and I believe the director of nutrition services here at Moffitt Cancer Center. Okay. Could you please come up and give us your talk? So let's get your presentations on the road.
It's still morning. Good morning. Good morning. It's truly a pleasure for me to be here. I feel almost like I'm cheating because it's a part of my job, and I love it. So, it seems like you're not supposed to like working, but I really, even on the weekends, I love coming out to do something like this because it's not only my job, but it's my passion to help to educate people about how they can reduce risk. Even every time I come out and talk to a group, I think if one person changes one thing in their eating habits or their lifestyle to help improve their quality of life or their health, then I've made a difference and I've done my job. So I really appreciate the opportunity. And I was also pleased to see the little banner across the screen with Steve Harvey where he had the risk factors, and all of them had to do with lifestyle except one, which was heredity, which means that we have a lot of power to change our risk factors, and that is within our control. So I'm here today to share with you what you can do to reduce risk and share that information with others. And the big question is, can changing the way we eat really help fight cancer? Of course, I believe that it can, but we now have research to back it up, and I'd like to share a little bit of that with you. And really, when we think back on it, our parents knew best and tried to tell us what to eat and tried to tell us to eat healthy foods, and we kind of went, yeah, all right, whatever. But now the research has proven that that is true. And there are so many choices and so much information out there. Sometimes it's hard to know what is based on science and what isn't. And we do rely on evidence to make our recommendations. I'm sure every day when you read the paper or you hear something on the radio or TV, you hear something new about nutrition, diet, fats are good for you, fats are bad for you, you should eat red meat, you shouldn't eat red meat, and so on. Have you heard that? Things like that, conflicting messages? Anybody? Yes. So it's hard to know what is the truth. Well, fortunately for us, in 2007, there was a landmark publication, and it was a collection of all the information from all the different research studies around the world that had anything to do with diet, physical activity, and cancer. And a group of scientific experts who were trained to evaluate research and the validity of those results, so we're comparing apples to apples and oranges to oranges, they had a systematic way of looking at all those research studies and the results of those studies to come up with the solid evidence-based recommendations that we have today. It involved over 100 scientists in 30 different countries. It's the largest of its kind, and it's the most reliable set of recommendations that we have so far. And what they found is that weight management, diet, and physical activity can indeed reduce cancer risk by as much as 40 to 45%. So we do have some control. Aside from the hereditary factors, we do have some control over our cancer risk because we do have control over these three factors. This was very exciting news for us as nutritionists because it makes my job more valuable to help educate you. So how many of you here are planning to become a dietitian? Nobody. I can't believe it. This is a very exciting field right now, so I would encourage you to consider it. Body weight and body fatness does increase risk for colon cancer, among other types of cancer. Abdominal fatness, in particular, was found to increase risk. So just by reducing abdominal fatness by 5%, we can reduce risk for colon cancer. So the recommendation is to be as lean as possible without becoming underweight. Doesn't mean be as skinny as you possibly can be, but be as lean as you can. And reducing abdominal fat, and the best way to measure whether you're reducing abdominal fat is to measure your waist. Actually, it's not the waist that we think of as the waist, it's actually an abdominal measurement, which is a little bit above the hip bone. And think of the largest part of your trunk, not the underneath or the above part of the fatty area. We all want to measure the skinniest part, but it's really the not skinniest part. It's the widest part. That's what you want to measure. If you embark on any kind of weight loss program, measure the largest part and then measure again in a few weeks and see if you're having an impact. Simply by reducing that abdominal measurement by a little bit is reducing your risk. So the body mass index should be between 21 and 23. If you don't know what your BMI is, and how many of you know what a BMI is? Everybody in the room. How many of you know what your BMI is? Good. So you know whether it's above or below this range. So if it's above this range, you need to reduce. If you're within this range, you're doing great with the body fat or the body mass. There is also convincing evidence that red meat is a contributing cause of colorectal cancer. Pork is not the other white meat, just to let you know. Years ago, there was this huge campaign. Remember the campaign? Pork, the other white meat. Well, that was the pork industry trying to get you to buy pork, of course. It is not a white meat. It kind of looks white, but it's not a white meat. It's actually any kind of red meat, even lean red meat, was found to increase risk for colorectal cancer. Red meat contains a substance that when it's digested and it hits the colon, creates chemicals that are toxic and carcinogenic to the colon. Also processed meat, like bacon. Yes, bacon is a processed meat. Sausage, many luncheon meats like salami, any kind of heavily processed salty meats, you know what those are. They're not only high in fat, but they also have been identified as being a risk factor for colon cancer. So the recommendation is, and this is the first time a major organization has come out with a specific recommendation for an amount of meat. The recommendation is to eat no more than 18 ounces of red meat, and that's the cooked red meat, the cooked weight. And again, that would be beef, pork, and lamb. And avoid processed meats as much as you can. And that also includes hot dogs. Hot dogs are a processed meat. Alcohol increases the risk of colon cancer, along with other types of cancer. And the risk for alcohol and cancer is actually greater in men than in women, with colon cancer. It is dose dependent, meaning those that consumed a greater amount of alcohol per day had a higher risk. And they only went up to 3 drinks a day in the study. So if you're above 3 drinks a day, you definitely need to cut back on that. But the highest level that they measured, which was 3 drinks a day, increased the risk for colon cancer by 41% in men. So if you consume alcohol at all, it should be no more than 2 drinks a day for men and 1 drink for women. And that means, like for wine, it would be a 5-ounce glass of wine. For beer, it would be 12 ounces, not a 16 or 20. So that's not 1 drink, that's more like 2. Physical activity, there was convincing evidence that physical activity protects against colon cancer. And that's all types of physical activity. And again, there's a dose-dependent response, meaning those who exercised more or had a greater level of physical activity had a lower risk. So more exercise means a greater protection against colon cancer. So the recommendation is to be moderately physically active, and that doesn't mean like strolling around your house, doesn't really count. We've had people who try to say, you know, cooking and cleaning, or if you're on the golf cart and you're riding, or golf course and you're riding in the golf cart, that doesn't count. But physical, active, purposeful physical activity, that's what we're talking about with physical activity. And as fitness improves, because if you're already doing 30 minutes of physical activity and you're not even breathing hard, you need to increase to 60 minutes per day on average. Also, plant-based foods. Plant foods contain natural cancer-fighting properties. They're called phytochemicals. That's P-H-Y-T-O, not F-I-D-O like the dog. It's phytochemicals. And that means vegetables, fruits, whole grains, beans, nuts. Eat 5 to 7 per day of fruits and vegetables. How many of you think you're eating 5 to 7 per day? 1, 2. Juice doesn't count. Okay, so some of you put your hands down. It has to be a whole, good, very good. So 5 to 7 per day of fruits and vegetables, and whole grains, cereals, beans at every meal. Some other specific foods that were found to reduce risk for colon cancer: high fiber foods like whole grains, brown rice, whole wheat bread. Garlic was found to reduce risk. Milk, and we do recommend low-fat or non-fat, even though it didn't seem to matter in the study, having milk and calcium reduce risk for colon cancer. Also, non-starchy vegetables, so French fries don't count.
I had a question. I thought your body couldn't digest fiber.
You're right. Fiber is actually called the non-digestible portion of food. That's the definition for fiber. But high fiber foods were found to reduce risk. So the fiber has a positive effect on the colon. The portion of food that's undigested actually has a positive impact on the colon. Good question. Foods containing folate, which are green leafy vegetables, again, oranges, orange juice, those are high in folate. Foods containing selenium, like nuts, fish, and foods containing vitamin D. Fish is one of those, especially the fatty fish. Those foods, in particular, were found to reduce risk for colon cancer. So definitely include those in your diet as often as you can. So the bottom line is to spend more time in the produce section and less time in the meat department. Eating right and exercise can help us to fight cancer, and in particular, colon cancer. So instead of this for lunch today, now this looks just as good, doesn't it? Thank you. It is possible to eat well, eat foods that taste good and are also good for you. We have a program here. If any of you are cancer survivors or you know of any cancer survivors, we have a program here at Moffitt called Renew, which actually helps you to put those guidelines into action. And I have some brochures on the table in the lobby. Feel free to stop by and take one if you have any interest at all in that. Thank you very much.
Well, we've all learned a little bit how to eat healthier and lose a little weight and exercise. And we all can benefit from those comments. The next speaker to come up is Dr. O'Neill. He happens to be a member of Phi Beta Sigma Fraternity Incorporated, and he's an internist here in Tampa that handles primary care medicine. Dr. O'Neill.
Good morning, folks, and again, I'd like to offer my thanks for your coming here today. I think these types of things are going to be really big for us, and I think the take-home message I'm going to give you now, and I'll also give it to you at the end, is go see somebody. I think all of you here have someone in your family who hasn't gone to see a primary care physician, and you can have a positive impact on that individual. So when you leave here today, let's go find that individual and make sure that that individual gets in to see somebody. I look at cancer screening in general, and colon cancer in particular, has been what I call a three-prong approach. There's a primary care guy. That's me. I'm an internal medicine doc. That's the gastroenterologist who does the procedures, as we saw Steve Harvey just going through. And then on the back side of that, the surgeons and the oncologists. While my part in that is relatively small, I think it's probably the most critical one. Because I'm the guy who sees you every day. And there are tons and tons of stories that I have about getting folks in to get these things done, but I'll share this one with you. I have one patient who's 73 years old right now, and it took me 18 months to convince this guy to go get his colonoscopy done. When he finally went, he had 2 polyps, both of which had cancer in the tips of those polyps. The polyps were removed, and he was cured. And I use that story often when I'm trying to convince a lot of my patients to get in and get these things done. And you'll be surprised the kind of stories that they can come up with sometimes for reasons that they don't want to get the procedure done. They're told it's painful. I say, it is not painful. Do you guys use anesthesia? You're asleep. You don't know what's going on. The toughest part is actually the day prior. I tell a lot of my folks about 6 or 7 p.m. the day before your colonoscopy, you're sitting on the toilet and you're sitting there saying, man, there's nothing else in there. Well, there's a little stuff in there, as Steve Harvey can attest. That's the toughest part about it. We looked at the environmental factors, the dietary factors, the exercise, and those types of things that can have a positive impact on cancer. I think that in the next 5 years or so, we're probably going to be able to bring genetics online to help us out with that. I was at a conference at the University of Miami about 1.5 years ago. I was talking on genetics then, and we now know that we can do DNA mapping on everybody. The difficulty right now is the cost. At this point, that's cost about $5,000 per test. We're hoping in the next 5 years so we can get those costs down. And the beauty of that is that now with DNA mapping, I can sit down and talk to a 25-year-old who may be at an increased risk for any number of medical issues, to include cancer, and begin to make those type of environmental changes at 25. And that's important from my vantage point, because invariably, a lot of us don't make changes to get to be 40, 45, or 50 after an event of some sort. It's my firm belief that if I can get another 20 to 25-year lead on changing lifestyles based upon your genetics, we're going to make a significant inroad into not only colon cancer, but all the cardiovascular issues as well. I had a thought that just left me. That's not good. That's my part in this, again, is very, very short. Again, my real biggie is go see somebody. That's all I can say to you. Go see somebody. Okay?
Thank you, Dr. O'Neill. You got to see your preventive, you got to have preventive care, wellness care, and maintenance care with all your medical issues with the primary care physician. I'm an anesthesiologist, and I work very closely to the gastroenterologist. We see each other a lot because we share in doing screening for these patients. He does the dirty work, and I pass the gas. So, but we use propofol for these patients. And on some very high-risk patients, we may need to put them to sleep. But we put them to sleep with propofol, which is an IV preparation of medicine. And unfortunately, it has gotten a lot of bad press with the loss of one of my favorite entertainers, Michael Jackson. But with somebody using it that's trained in controlling and watching a patient's vital signs and knowing how to use the medication. It's a very, very useful medicine that can make a patient unaware of having a colonoscopy or any kind of invasive procedure. Okay. Now, I'd like to, at this time, introduce Dr. Shivakumar Vinyesh. He's assistant professor of gastroenterology here at Moffitt Cancer Center.
Good morning, everybody. Good morning. Yeah. Thank you, Dr. McCoy, and thank the Kristen Foundation, and thank one of my colleagues and friends, Dr. Hoff, for getting me involved with this. I'm very happy to be here. And I enjoyed the talks before, Dr. Green and Dr. McCoy and Kathy Allen. A lot of good points. So my goal, I'm a gastroenterologist, and as I think about this, I think my main objective is to remove any fears you have about colonoscopy. And a lot of you are very young here. I hope you'll talk to your parents or relatives, and if they've not had a colonoscopy, and if they're over the age of 50, and if you're African American over the age of 45, you have to convince them to see their primary care doctor, like Dr. O'Neill, or a gastroenterologist. They should at least talk about it. There are other options for those of you or your family who don't want to have a colonoscopy or concerned. So let's move on. So colonoscopy, you know, it's not at all bad. Okay, it's actually, you know, I don't even. It's actually a very quick, fun, easy procedure. You know, it's all you know, like Dr. O'Neill and actually Dr. McCoy was saying, we have anesthesiologists here at Moffitt who give anesthesia, and it's just like an IV medicine. You go to sleep, and then you wake up and you talk to the doctor. It's painless. It takes 20 minutes when an experienced doctor does it, maybe 30 minutes. So it's no big deal at all, like Steve Harvey was saying. I mean, the big deal is to actually make sure that the person who needs it gets it. That's the important part. So colon and rectal cancer will together club them as colorectal cancer. The rectum, you know, is just part of the colon, but has a little bit of, there's some differences in treatment, so it's listed separately, but it's a third common cause of cancer death for both men and women. About 150,000 new patients are diagnosed with colorectal cancer every year, and a third of them, or about 50,000, die every year from colon cancer. So it's a huge problem. And not only is it the third common cause of death, it's also the third common cancer in men and women. It's very rare under the age of 40, because if you have a family member, particularly a sibling or a parent who has colon cancer, your risk goes up significantly. If you have second-degree relatives, who more than one with colon cancer, then you might have to get a colonoscopy under the age of 40. So you have to talk to your doctor about that. But most of the cases happen over the age of 50. And the lifetime incidence is about 5%. And in African American men and women, the incidence is as high as 20% higher. Okay. Unfortunately, studies have shown that the death rate is also almost as high as 50% higher. So it's very important to screen African Americans early. So that's an important point. So this is the large bowel, or the colon, and is this a laser pointer here? Anyway, so you can see the different parts of the colon, from the rectum to the left colon, or the descending colon, the horizontal part called the transverse, and the right colon, or the ascending, and it ends in the appendix. We go through the entire length of the colon, and it takes about 20 minutes to do that. And then we carefully inspect the entire colon on the way back out, and if there are polyps, like somebody else pointed out, we could easily remove them, and therefore we can prevent the polyp becoming cancer. So there's another just cartoon showing all these different problems in the colon. So even though our objective is to detect cancer early, quite often we can diagnose other conditions with this test. This is a little picture of a growth. On the left you can see it's labeled tumor. And the cartoon here shows how a small polyp grows, and as it grows out into the colon, it also grows deeper and gets into the blood vessels. Our goal is to prevent the polyp growing into a cancer, so we want to detect it early and remove it. So we already talked a little bit about that. But since 1970 or 1980, death rates have gone down significantly. And this is primarily because of early detection, awareness, and screening. Also a little bit because of improved treatment. And that's why we need to keep that momentum going. However, the decline has not been observed in African Americans. So that's the message. We need to increase awareness and improve screening. So the U.S. has low mortality, and most patients do survive. 2/3 of patients survive 5 years. So what are some of the risks? We talked about family history. So if any family member has polyps or colon cancer, your risk may be high. You should just talk to your doctor about that. You may need colonoscopy sooner. If you yourself have a history of polyps, you want to make sure you have a follow-up. If you have colitis, common types of colitis or ulcerative colitis or Crohn's disease, then your risk may be higher. If you have any inherited conditions, that's a minority, but then your risk is higher. Diabetes, obesity, we already heard about that, the BMI, the lifestyle, so I'm not going to get into that, but they all affect your risk. And radiation in the past can affect risk of rectal cancer. We all also heard about protective factors. Fiber, somebody asked a question. Fiber is thought to just improve transit or the speed of the contents going through the colon, and that's probably what affects the risk, because if the stool stays in the colon for a very long time, it's broken down into these byproducts which may contribute to cancer. Physical activity is important. Aspirin is thought to have some protective effect. So signs and symptoms. Most patients have no symptoms, and that's the reason everybody should get a screening procedure over the age of 50. Abdominal pain is usually a late symptom. Change in your bowel pattern or habit, change in the calorie of the stool. This is quite amusing to read, but it kind of helps patients understand how the stool can differ. It is, somebody took the time to make up such an elaborate classification. So, it does, any change in the pattern, sudden new constipation is actually very, very important. Rectal bleeding, or as a result of bleeding, you can have anemia, which is a low blood count, or weakness. They're all concerning signs. So unfortunately, some of them are late, and unexplained weight loss. So the point of this slide is, yes, we have family history, familial cancer. We have rare, actually not that rare, the genetic syndrome is called familial polyposis, where cancer happens by the age of 30, and people who have that syndrome. Other rare syndromes, most of cases are sporadic, okay, the bulk of the cases. So again, that's why we recommend that everybody, regardless of symptoms, get screened over the age of 50. So colonoscopy is a preventive test. There are many tests, such as checking the stool for blood or other stool tests, which detect cancer. As I'll mention again, I'm going to mention it now just so that you hear it twice, they don't detect polyps, most of those other tests. And they certainly don't help remove polyps. So colonoscopy is the only test that detects the precursor lesion, the polyp, and removes it so you don't get cancer. Now, as we heard, the prep is cumbersome, but there are different options for those people who can't bring 4 liters of a clean-out. Now, the procedure is definitely painless. We have anesthesiologists and nurse anesthetists who are very experienced, give intravenous propofol. Even in places who use a Valium type of sedative, it's painless. The procedure is very short. Now, the bottom part is, again, to tell you that the awareness is not as high as we would like, and, many physicians, I'm sure Dr. O'Neill and people who are aware tell patients about getting a colonoscopy, but, most people are not. At least half physicians are not telling patients. So this is the clean-out, okay? This is actually our favorite clean-out, and most patients ask you, why can't I drink something more compact? The main reason is this is the safest clean-out. It's 4 liters, but it doesn't add a drop of fluid to your body, or it doesn't remove fluid. So it's safe for patients with kidney failure, heart failure, liver failure, safe for everybody. And it also gives the best quality clean-out. And guess what's the biggest determinant of the quality of the procedure? The clean-out. And it also actually, if the clean-out's not good, the procedure is longer. So I think it's time well spent, and if you get a good clean-out, then you get that 10-year warranty we heard about. If the clean-out's not that good, sometimes we get to give you a 1-year or a 3-year warranty. So, that's actually a very important part of the procedure. We can use anesthesia, or we can use a Valium type of sedative. So I already made this point. We have all these flavor packs with new lightly. Patients seem to find that it's more palatable if you use some whatever flavor you like. Now, the other part of it is clear liquids the day before. And black coffee or tea does count as a clear liquid. What we mean by clear liquid is no pulp, nothing red, nothing red, and no dairy. Yeah, dairy doesn't count as a clear liquid, as our anesthesiologist will tell it, So clear liquids do help with that. Those of you who have family or friends getting ready for a colonoscopy, you can educate them. And follow the instructions, and if you have any questions, you just call us, and we'll make sure everything's okay. And the other important part is to take your essential medications on the morning of the procedure. A lot of patients skip their heart medicine or pain medicine. So, we go through all this, and I'm sure most gastroenterologists do. So this is a normal colon. This is what a clean out or prep, as we call it, looks like. And you can see even the little blood vessels in the wall of the colon. This is a patient. This is how you lay on your left side. Like you're sleeping, you're comfortable, and most people don't even know it. So these are some examples of polyps. They come in all different shapes and sizes, and you don't have to know the medical name, but their polyps are different under the microscope, and most of them are these adenomas, which are precancerous. And the point of this is that it's well established that polyps over a 5 to 10 year period will become cancer through a variety of genetic changes. And that's why colonoscopy is such a great test. It removes that polyp, so you can't get cancer. So different shapes and sizes of polyps. So on the top left, you see a polyp which has almost become cancer. On the bottom, in the top left, in the bottom left, you see a cancer. So we want to catch it ideally before that. You see a crater in the middle. It's a cancerous polyp. Then on the top right, you see a benign polyp. This is what we could easily put a lasso around and get rid of it. And in the bottom right, you can barely see this polyp, and that's why the clean out is so important. And once you see it, we could remove it. This is just an example of how we remove a polyp. I don't actually show you that wire or a lasso or a snare, but we inject some methylene blue or dye to mark that area, so when we come back the next time, we can check. And also it gives us a good idea if we remove the polyp completely. This whole procedure removal takes less than 5 minutes. So briefly, imaging has gone through a lot of improvement. We have a lot of tools that improve the ability to detect polyps. This tiny little polyp on the left is better seen when it's magnified, and these may not be seen. You might have heard the virtual colonoscopy or CT colography. I have one slide on it. And the issue many gastroenterologists have with that is many small polyps can be missed because they have size criteria. They do not count anything as a polyp if it's less than 6 millimeters. And quite often, like this one, it can be a precancerous polyp with this pattern you see on it. It looks like a brain. That's a precancerous polyp. So we have other techniques to detect small polyps. This is a blue light filter. Shows contrast better as it shows blood vessels better. You see polyps that see on the left, on the top, you can barely see it. So we have all these little tools to help us detect polyps. So the American Cancer Society, the U.S. Multi-Society Task Force on Colorectal Cancer recommend one of these colorectal cancer screening tests. So the first category is tests that detect cancer. CRC is colorectal cancer and polyps. That's important. And that's colonoscopy every 10 years, or this virtual colonoscopy or CT colography every 5 years. And tests that are great for detecting cancer but poor for polyps. You have the fecal immunochemical test. In the past, we used to do a stool blood test, occult blood. Now that's completely gone out of favor because it detects only about 20 to 30% of cancer. And it's even poorer for polyps. And there's a DNA test, which is pretty good, but it's very expensive. So the American College of Gastroenterology has a different approach. Rather than giving lots of different options, they just tell patients, this is our preferred test. And obviously, they prefer colonoscopy. And the reason I already went over, we could not only detect, but remove the polyp. And every 10 years, if it's normal, beginning at age 50, at age 45 in African Americans. And we already went over the other options. Now, there's an old test called barium enema. It should never be done anymore. It's considered to be very poor for detecting cancer or polyps. So just one slide on the virtual colonoscopy. You know, our president got this recently, so it got some press. So it's a 3D CAT scan, okay, to view the entire colon. Like on the bottom, you can see it's like a CAT scan. You see some polyps, or you can have this animated view of going through the colon. Now, there's a few points about it. You still need to clean your colon out. Air is pumped into the colon. I've had patients who came back and told me that it was not as great an experience as they had thought it would be. And if polyps are found, you will need a colonoscopy to remove them, okay? So if you're a higher risk patient, you're better off just getting the colonoscopy. And it's likely to miss small polyps. And quite often, small polyps are when you can completely prevent cancer. So if patients who, for some reason, we cannot complete a colonoscopy, sometimes they have surgery and they have scar tissue, then we may recommend the CT scan or virtual colonoscopy, or patients who are very high risk. But most patients should get a colonoscopy. So I'm going to stop right there. And this is the Moffitt. We had the super colon, which actually I believe goes throughout the country, where you can walk in an inflated colon and you can look at polyps and so on. We had this. I just put it in there. We had it last year. So I'm going to stop here and answer any questions that you have. Thank you. Yes?
Sometimes things come up. I know you said 45 or whatever happened there. I'm 36. What should I do for 36? I don't want to look at 45.
Well, if you have no family history, colon cancer, and if you don't have any symptoms, then you're fine. But if if somebody who's younger than 45, regardless of their race, if they have any symptoms referable to the GI tract, such as diarrhea or sudden change in your bowel pattern, new constipation, pain, then you should talk to your primary care doctor. But if you're healthy and you're under the age of 45 without any family history, then you don't have to worry about it. Diverticulitis, basically what that is just for the sake of everybody to understand that a common condition is in the colon in people who are older than the age of 50 is you get these little pouches or pockets from constipation and straining. The inner lining just kind of protrudes out, and that's a benign condition. Rarely it can get blocked with stool, the little pocket or pouch, and get an infection, and that's called diverticulitis. It can also rarely cause bleeding. That does not increase the risk of cancer. However, cancer can masquerade or present as diverticulitis. So any patient with a history of diverticulitis should get a colonoscopy about 6 to 8 weeks later, after that episode is completely healed and resolved. So that's the important point. It doesn't itself increase the risk, but it might be masking cancer.
I noticed in one of your slides, it had the progression from polyp to precancers to cancers, but on the far end, I noticed that you said mucous membrane or something like that. Yeah, the normal mucosa. Is the cancerous polyp, does it come out of the mucous membrane under the body?
Well, the colon has a great question actually. The colon has glands like all the entire bowel, and these are little crypts. They go down into the lining, and the earliest abnormality that is detectable, we can actually detect it with a special type of endoscope. It's a microscope on a tip of an endoscope. It's available now. Many institutions have it, but it's not for day-to-day use for research. You could see abnormalities in that crypt or the gland, and you can actually predict that it's going to form a polyp and a cancer. So we're able to detect the earliest lesion, and we don't know what to do with it yet. It's still in that research phase. But maybe in 5 to 10 years, we'll have either medications, either pills, or something endoscopic we could do about it. So far, we just know to detect it. Yes, Dr.
Hemorrhoids, precancers.
Hemorrhoids are not precancerous, but again, kind of the same theme as the diverticulitis. Sometimes anal cancer hides in hemorrhoids. Vast majority of people with hemorrhoids have nothing to worry about other than the symptoms of bleeding and itching and pain. However, at least a doctor should examine that area in the office carefully to make sure there's no, small cancer hiding there, because that's something which I've seen, picked up later.
My question is right online with the hemorrhoid.
Yeah, by itself, it's not a problem, but if it's causing significant symptoms, your primary care doctor or a gastroenterologist should examine that area.
The stool chart that you commented on or whatever,
Mm-hmm.
I think all of us saw some of one of those at one point in time, and I liked it. What did the type one, like?
I put it more for fun,
I'm like, I remember that.
I was amazed that somebody went into this great detail, like type 3 versus type 2. I mean, it just amazes me that somebody is so detail-oriented. However, huh? I know. Yeah, I was just going to say, most people say, oh, I don't have constipation, but then I look at their colon and I know they've had constipation. So maybe, when you show them this, they would say, oh, wait a minute, I'm actually type 2, which that's constipation. So, in patients with lots of pain and diarrhea, this irritable bowel, which can be constipation or diarrhea or pain, that's when this is used, to get a clear idea of how your symptoms and if you have bad constipation, how things are improving or not. So it helps you to objectively follow patients for improvement. But, I just thought it was interesting that we had such an elaborate classification. All right, thank you very much. Thank you. I'm happy to answer one more if we have time.
So, curiosity state, which one of those are we supposed to be at?
Yeah.
See, type 1 and type 2 are definitely signs of constipation. Type 3 tells you that it's still probably closer to the constipated side because it's cracks on the surface. Type 4 would be the closest to quote-unquote normal. Type 4 and 5 would probably be okay. Type 6 and 7 are going into the spectrum of diarrhea. But, it's relative. The point is sudden change in the bowel habit.
Thank you, Dr. Vignes, for your contribution. I have a Lou Rawls video that I was going to show, but it kind of looks like Dr. Vignes. She's the co-lead. But anyway, have you seen that video? Well, maybe I should share it for you later. It's pretty funny. This is Dr. Sophie Desereau. Thank you, Dr. Desereau, for coming. She's Associate Professor, Surgical Oncology here at Moffitt.
Thank you. And if you hear a lot of wailing out there, I have a 15-month-old that I just left, so he's... So as was mentioned, I'm a surgeon, and patients will get referred to me after they've been diagnosed by an endoscopist like Dr. Vignes, but you're going to see there's going to be some overlap in some of the material that I'm going to cover, because I think it's really important to stress the importance of screening. Because ultimately, the treatment, whether it be surgical, medical, chemo, radiation, the treatment and the prognosis of any cancer, and colorectal cancer is one of those cancers, depends 100% on the stage, okay? So if you can get diagnosed early, and this is the whole point of screening, is to try to identify a cancer before it's too late, the treatment is easier and the prognosis is better. So I can't emphasize that enough, and we try to send that message out to as many people as we can. So every cancer, whether it be lung cancer, breast cancer, colon cancer, is staged so that we can plan our treatment accordingly. We don't give the same treatment to everybody. Obviously, if you have a very advanced cancer, we have to be more aggressive with your treatment and try and cure you. If you have a very early cancer, there's no point in over-treating you if we can cure you with lesser therapy. So stage 1 and stage 2 cancer, colorectal cancer, is a very localized disease and can be treated with fairly local therapy and does not require chemotherapy. Stage 3 means that the cancer has spread to the regional lymph nodes. And stage 4 means that the cancer has spread to other organs, the liver, the lungs, the bones, and that sort of thing. Again, I cannot overemphasize the importance of colonoscopy screening. Some facts that you've probably heard already today, and I'm going to go through this part fairly quickly. Colorectal cancer is very common. It's actually the 4th most common cancer in America. It's the 2nd cause of cancer deaths in the USA after lung cancer. And over 90% of cases are diagnosed in people over the age of 50. Now, we do have patients in their 20s, 30s, and 40s, and I just had one last week. But for the most part, they're over the age of 50. And it's estimated, and we don't have proof of this because screening isn't across the board yet, but it's estimated that half of colorectal cancer deaths could be avoided if people over the age of 50 had regular screening with colonoscopy. And when we say screening, we're meaning every 10 years. So it's not like you have to go every year like mammography. It'd be every 10 years, and it's estimated that half of the deaths due to colorectal cancer could be avoided. So if you have an early detection and you treat the patient at the time of early detection, there's a 90% 5-year survival from that treatment. So that's very good. Now, the number of deaths from colorectal cancer has been dropping over the past 15 years, and screening colonoscopy has played a role in that, not only for prevention, because if you have a benign polyp in your colon, not only, and that's taken out, you prevent the cancer from even starting. So it's even better than mammography. Mammography only does early detection. If you have a mammogram and it shows carcinoma in situ or breast cancer, you have to go for your treatment. But there's nothing that a mammogram can do to prevent breast cancer. It's just screening. Colonoscopy can actually prevent it because it grabs the polyps before they even become malignant. So prevention and early detection, early treatment. And also, you'll hear next, the chemotherapy drugs have improved significantly over the past 10 years. And all of these 3 things has improved the survival and decreased the number of deaths. So at this point, there are over 1 million patients who have survived their colorectal cancer in America. As I mentioned before, the 5-year survival for early stage colorectal cancer is greater than 90%. Again, all the more emphasis for why it's important to do colonoscopy screening. Less than 40% of colorectal cancer patients, however, are diagnosed at such an early stage. Most patients get diagnosed with stage 3 disease. So it's not too late, but the odds are more against them. So survival can be improved with early detection and treatment, and then once they have colorectal cancer, we can improve their survival somewhat because of the improved therapies over the past 10 years. Risk factors for colorectal cancer: age over 50, a family history of colorectal cancer, a personal history of colorectal. If you've had one colorectal cancer, let's say you had a cancer in your right colon, you have an increased risk of getting one in your left colon because you've eaten the same food over the past 40, 50, 60 years of your life. The food has gone through your colon, so whatever agents have contributed to one colon cancer, they're going to contribute to the second one. Plus, your genetic makeup is the same in your entire body. So whatever genes you inherited from Uncle Harry and Aunt Jane that contributed to you getting the colorectal cancer in the first place, you've got those genes in your entire body. So the rest of the colon that's left behind has an increased risk of getting colorectal cancer. Similarly, if you've had a history of polyps or diabetes, you have an increased risk of colon cancer. Ulcerative colitis, Crohn's disease, and certain hereditary conditions, which are not common, but if you have them, they certainly increase your risk of colon cancer. And your ethnicity, for instance, Ashkenazi Jews and race, African Americans, have an increased risk of colorectal cancer. And so those populations, we try to emphasize even more the importance of screening. Certain things cannot be changed. You can't change your age, you can't change your personal history, your family history, but some things you can do. And it's been shown that certain things might improve your decrease your risk of getting colorectal cancer, increase physical activity, decrease obesity, decrease smoking, alcohol consumption, and then, as I mentioned before, the screening. There's a few things that we don't know if they have any clear effect, but there's some suggestion that they may play a role, and I think you've probably heard about that earlier today. I kind of like this. Hopefully you can read it. I'd have been here sooner if it hadn't been for early detection. So even some cartoonists appreciate the importance of screening. Patients say, well, I don't have a family history. Well, that doesn't matter. 75% of patients have no family history. They still get colorectal cancer. So everyone is at risk, both men and women, and we talked about the colonoscopy every 10 years. So I want to cover a few myths about screening. One myth is that colonoscopy is performed only to detect colorectal cancer, like mammography. Again, I mentioned that that's not true. It actually prevents colorectal cancer from ever happening. Some people have heard of virtual colonoscopy or CT colonography, or the pill cam or a camera that you swallow that looks at your colon. They say, well, I don't want to have to, have that big long snake tube stuck inside of me. I don't want to have that done. I would rather do one of these more high-tech things. It's got to be better. Well, that's not true, because if these high-tech things see something, they can't do the biopsy. So then you have to go and have a whole bowel prep all over again and have your colonoscopy done. So you may as well just get it done once and not have to go through it twice. And then some people say, well, there's a lot of risk to colonoscopy. That's not good. I've heard you can perforate, you can bleed, all these things. Well, the risk of complications is about 0.1%. So it's not zero. There are risks. But the risk of developing colorectal cancer in your lifetime is 6%. So the benefit clearly outweighs the risk. Another myth is that colonoscopy is painful. Well, these days, most patients have colonoscopy under sedation. So it's done under comfort, and most people don't even remember having it done. And some people say, well, the bowel prep's really horrible. You got to drink this gallon of Go Lightly. There are numerous bowel preps that have been designed at this point, so they're not all the Go Lightly. You have some options. Skip that. So back to staging. Remember I said that the treatment and the prognosis depends on stage? So the early stage is stage 1 and 2. Regional is stage 3, where it's gone to the lymph nodes. And then stage 4 is when it's gone to other organs. So what's the treatment entail as far as surgery? Well, let's start with the easy statements first. If you have metastatic disease, so if you have not had your screening and you present because you've had some symptoms and your cancer has already spread to your liver or your lungs or other organs, you're going to need chemotherapy no matter what. You may need surgery as well, but you may be beyond surgery. And we tell patients that the chance of cure with metastatic disease is low. Certainly, if you have one metastasis, you might have, if it's resectable, you could have a surgeon cut out the metastasis, and you might have a chance at cure, but the chance is 20–30% at best. So certainly, you want to have your disease diagnosed before stage 4. Patients who have no metastatic disease, if it's caught early, so stage 1, stage 2, then surgery alone may be curative. You may not need chemotherapy. You may not need radiation. But if you've had spread to your lymph nodes, you will need chemotherapy to improve your chances of survival. And people say, well, would I have to have a bag, a colostomy bag? That's not just simply based on stage, but also on the location of your tumor. So if your tumor is near the sphincter, so at the bottom of your rectum, even if it's a relatively early stage, you might still need a colostomy bag. And it may not be related so much to the stage. You could have a stage 3 cancer of your right colon and not need a colostomy bag. So that's a whole different discussion. But most patients with colorectal cancer do not need a colostomy. So if it's caught early, then sometimes it can be cured just with colonoscopy alone. Dr. Vignash and his colleagues can actually remove early cancers without a surgeon like me having to go in. Now, if you do need surgery, we have some newer techniques in the past 5–10 years that avoid a big major operation with a big incision and long hospital stay. You can consider laparoscopic surgery, or if you have a rectal cancer, you can actually do the surgery through your anus, so you don't have any scars on your belly. And it's like a hemorrhoidectomy almost, and you can go home the same day. But this is only possible if it's caught early. If you have a rectal cancer and it's not caught early, you cannot have the anal approach. You have to have the abdominal incision. So again, to kind of emphasize that if you want to have local excision and minimal surgery, it's got to be very early. So again, this is probably only going to happen if you do screening, because most early cancers have no symptoms. That's the whole reason for doing the screening in the first place. People say, well, I feel fine. Well, that's the point. Most people feel fine until it's too late. So for transanal excision, we have an instrument. It's like when you go to the gynecologist and they have a speculum. We have a different speculum for the rectum, and we work through the speculum, just like this picture is showing. But I just want to emphasize in the yellow font there, this is only for T1 and 0. It means you cannot have any lymph nodes positive, and the cancer cannot be a T2, T3, or T4. It's got to be a T1. It has to be an early lesion. There's a more recent technique. Sometimes the tumor is too far up to do the transanal. You know, the speculum I showed you in the last picture, you can only go so far. You know, the gynecologist, the vagina is only so long, but the rectum is actually longer. If you have a tumor higher up, you can't do it the old-fashioned transanal approach with that speculum. There's a new machine, this green thing there, that allows us to do transanal endoscopic microsurgery. And that allows you to go a little bit higher up, and still you can have the surgery without an abdominal incision. And as I say, it's done through the anus. So there are some improvements in technology that are allowing us to do these minimal cases, but these only apply to patients with early cancer. So you can go up to 18 centimeters, which is 8 inches. 8 inches. So you can't do that with the little speculum, but you can do that with the TEM. So this traditional surgery that you may have had some friends or colleagues have, colon resection, they have a midline incision up and down through their belly. And this is an example of the, oops, that's not that word. Okay, how do I get rid of the, okay, got it, okay. I thought I had a pointer, but that's okay. You can see this is a patient who has that red tumor at the top of the rectum. So the picture on the left is your normal anatomy, and the cancer is that sort of pale-looking thing at the sort of middle to top of the rectum. The colon is that U shape, upside down U, and then the surgeon takes out what's delineated in the red box in the middle picture. And the reason you say, why do you take all that out if the tumor is just that red circle? When we do colorectal cancer surgery, we want to remove the lymph nodes to make sure the cancer hasn't spread to those lymph nodes. And those lymph nodes are the little black circles in that red box. And then what we do is we take the top of the colon and hook it up to the bottom part, the top of the rectum, and so you end up with what's shown there on the right-hand side, where the black line is the suture line between the colon and the rectum. So we can do that with a lot of patients. But again, it's major surgery. Patients are in hospital for 5 to 10 days. And if you are detected early, and Dr. Vignesh can remove the surgery without big operation, you're way better off. And your prognosis is better, too. Why bother with laparoscopic surgery? Patients have heard about it. They say, you know, instead of having a big, long incision, you have 3 or 4 little holes the size of a pencil eraser head. There's a lot of technology. And you may have fewer complications. And the survival is the same, it's not worse than the old-fashioned surgery. Studies have shown that. So the outcomes are actually not better as far as survival, but at least they're the same. Patients stay in hospital much shorter than with the traditional open surgery. Their bowels wake up faster, so they're able to drink and eat a little bit faster than the open surgery. They definitely have less discomfort. They bounce back a lot faster. They go back to school, back to work, back to whatever they're doing. And they may have fewer wound complications than the old-fashioned surgery. And they definitely have a smaller incision. There are some challenges, so not everybody is a candidate for laparoscopic surgery. However, when we can offer it to patients, we do. We want to make sure that when we do the procedure laparoscopically that we're doing the same cancer operation. We're not cutting corners because we want the cure rate to be just the same. We don't want to increase recurrence rates. We don't want to have recurrence where the ports went in. We want to make sure the patient has the same survival as if we did it the old-fashioned way. It's been shown now over the past decade or so that laparoscopic surgery certainly can be used safely and with a good cancer operation with colon cancers of the right, the left, and the sigmoid colon. Those studies are out there and clear. Bottom line, and I started with this, and I'm going to finish off with this, is that the colonoscopy is really, or the screening is really the emphasis here, because you want to avoid having to go to see a surgeon and have a major surgery. You want to avoid a colostomy bag. So the colonoscopy not only detects early lesions, which allows you to have treatment earlier and improve your prognosis, but also prevents cancers in the first place. And people say, you know, I really don't want to have that colonoscopy. Well, you really don't want that colostomy bag either. And since you're not going to be able to pick where your cancer is going to be, and you're not going to know what stage it's going to present, wouldn't it be much better to have your colonoscopy once every 10 years? And it's like insurance. You're just going to try early detection and avoid having to have major surgery and a risk to your survival. It's much easier to treat and cure cancer if it's caught early. I think this is my last slide. Yeah. Any questions? Yes.
Go about promoting this test? I know it's an issue in the community, but how do you go about promoting it when it comes to
So your question is, how do you promote screening?
Yes.
Things like this. I've given talks in various other programs to the public. Invitations, I don't turn them down because I think it's important. You talk to, like if I have a patient, I make sure that their family is aware of what's going on and that they get screened. And then I tell them, look, you've been diagnosed with colon or rectal cancer. If they're at work, I say, go talk to your colleagues. Tell them, look, they don't have to go through what you're going through. Tell them to be screened, in their office, at their family family reunions, whatever. So it's word of mouth. I don't have a system except to just keep encouraging people, and you know, now whoever's in this room can spread the word tonight at dinner to whoever's having dinner with them, and then on Monday morning, if they're at work, talk to your colleagues at work and say, hey, I heard this on Saturday. I didn't realize that there's all these myths about colonoscopy. You know, I think we really should do this. I don't know that anybody has any better suggestion, but I think that's a good place to start. So those that are converted, you know, spread the word. It's important. And we teach to medical students. We want to educate. They're not all going to become oncologists. They're not all going to become cancer surgeons or cancer chemotherapists, but they'll go into family practice. So we want to teach them the importance of this so that when they're the primary care physicians, they tell their patients the importance of this. So that's another mechanism. Anybody else have any suggestions on the panel? What's that? Right, yeah. And ultimately, it's a culture. So ultimately, society will, for instance, mammography. It took a while for women to kind of grab, I mean, it's still not 100%, but it's way better than it was 30 years ago. And it's a culture of acceptance and you know, coming to understanding the importance of it and the worthiness of it, and that it's not a bad thing, it's a good thing.
Once a person received the colon resection, what's the possibility of the return of cancer?
It depends on what stage it was at. So again, the treatment and the prognosis, so recurrence is going to impact your prognosis. So if you have a very early stage cancer, the chance of recurrence is very low. And so your cure rate is very high. If you have a very advanced... For
person stage 3, for example.
Stage 3, so
yes.
You know, there's stage 3 and there's within a stage there's different parts, but so stage 3 means that you have lymph nodes involved. If you have just one lymph node involved versus 12 lymph nodes involved, it's going to be different, okay? So somebody who has 12 lymph nodes involved, and have I ever seen that? Yes. Their chance of recurrence is almost 100%, okay? In fact, I haven't seen somebody with that many lymph nodes not recur. But if you have just one, and I don't know if you're going to be talking about that in your, with prognosis and stuff. So depending on which studies you look at, there's a range, but basically you're looking at probably like 40% recurrence rate if you have lymph node positive. So again, just caught early, it's less than 5%. So and if it's 12 lymph nodes, 100%. So the earlier you catch it, the less the recurrence rate. So you can have the same operation, but the recurrence rate is higher if you've had worse disease.
If you have any questions, raise your hands. I'll bring the mic to
Yeah,
you.
there's one behind you.
Thank you. You stated that after you've had your colonoscopy, you're basically good for 10 years. Are there any recommendations less than 10 years?
Yeah. So if you have polyps, so if you had something abnormal, then you need to have it repeated before then. So if they're pre-malignant polyps, you probably have to go back within a year or two. But if your colonoscopy was clear, there was no polyps, nothing suspicious, you are good for 10 years, unless you have a family history or you have other risk factors that put you in a higher risk. But for the most part, and I don't know if Vignesh covered that, but for the most part, 10 years is sort of the guideline. Unless you have if you've had a cancer yourself, then we go more 3 to 5 years. But I'm talking about people that have never had cancer before, and that's 10 years. So it's not like mammography where and there was a question here?
Yes, how can you have new service provided without money or without insurance?
I don't know that I'm the best person to answer that. I'm from Canada. So in Canada, it's covered, okay? So you've not asked the right person. What's that? Yeah, or help the new system implement better health care.
I spoke to the lady that was out there with the American Cancer Society, and she said that they do work with the different insurance companies to try to get the screening done.
Right. I think the insurance companies are going to realize, if they haven't already, that it's better to pay for the screening because the cost of treating a patient with colon cancer when it's more advanced is way more than the cost of the colonoscopy up front. And then that's how the government of Canada thinks about it. They want to pay for the mammograms and they want to pay for the colonoscopies because it's a lot cheaper to prevent the cancer in the first place than to wait till the person has a horrible situation and then you're paying for major surgery, expensive chemo, radiation, complications, loss of work, you know, all the issues that occur with once you have a more advanced situation. So you have to, the payers, obviously here you have multiple payers and the American Cancer Society obviously sounds like they're working with the insurance companies to try and support that. Any other questions? Thank you for your attention.
Cost, insurance. What a catch-22 in this country, but hopefully it gets better. Thank you, Dr. Desreau, for your very timely remarks. Next on the list of panelists is Dr. Khaldoon Almhana. He's a medical oncologist here at Moffitt.
Thank you. Okay, good morning, everybody. I don't have slides because I hate slides. Anybody hate slides as well? I like the idea of talking in family reunion about colonoscopy, like family reunions are not awkward enough. So sit and talk about colonoscopy. So I'm the cancer doctor. I'm the doctor when you didn't do anything they've been telling you to do this morning, you're going to end up in my office. It's important. I mean, I missed most of the things in the morning, and I can say that I was busy, but the truth is I was sleeping. So I missed most of the morning sessions. So I'm the cancer doctor, and one of the things that are very important is for you to know who your doctors are. So when you have cancer, you're going to have 7, 8 doctors taking care of you, walking in and out and bossing you around and telling you, we're going to do this and that. Just know who's the surgeon, who's the medical oncologist, who's the radiation doctor. And that's very important because when you have a question, you want to send the question to the right person. and just don't mess them up. And then I see a lot of time that the patients don't know, oh, some doctor told me. So you have to know who's who and who did what. So I'm the medical oncology, I'm the cancer doctor, I'm the one who treats with chemotherapy. Cancer doctors are usually the better looking ones than surgeons and radiation. Okay, so our goal today was to scare you and make you get a colonoscopy as soon as possible, talk to your family about it, and hopefully that we achieve our goal. And because if you don't, you're gonna end up in my office. And I'm funny and everything, but I'm really tough when it comes to treating cancer. So if the cancer gets caught early, very, very early, when it's a small polyp or a very early stage disease, you don't need to see me. Even Dr. Desoro won't send you to my office. But if it's more advanced, you're gonna end up in my office and you're gonna end up getting chemotherapy. And I don't want to scare you from chemotherapy. We'll talk a little bit about it. Anybody here is a cancer survivor or a cancer patient currently? Hi. I always admire patients because what you go through is just amazing. So if your cancer is too early, you're not going to see me. If your cancer is bad and it spread to the lymph node, or sometimes even it didn't spread to the lymph node, but it's at a certain level where it's the largest perforating, it's whatever, we will end up needing to give you chemotherapy. The goal of chemotherapy is to increase your chance of cure. Can we be 100% positive that we're going to cure you? 100% no. I wish we can say it's 100%, but it's never 100% in cancer. Somebody asked the question about what the percentage of the disease coming back if I'm stage 2 or stage 3 or stage 4. Let me tell you something. For you, it's either 100% or 0%. You are going to do whatever you have to do and then just hope for the best. Even if it's 40%, you might be one of the 60%. Even if it's 90%, you might be part of the 10% who get the disease back. You just follow what the doctor tells you, bring them candies, and you're fine. So chemotherapy, when we resect the disease, you hear all these horror stories about chemotherapy, or you've seen somebody who's gone through it before, and you say, oh my God, they threw up a storm, they were in bed. That doesn't happen anymore. And if it's happening, you need to talk to your doctor, because we have a lot of good drugs to prevent nausea and vomiting. My patients, I try my best to get them through 6 months of chemotherapy without stepping a foot in a hospital and staying overnight in a hospital. There are certain instructions that they have to follow. I don't know, how did your chemo go, ma'am, when you had chemo, or are you still having chemo? Oh, you're doing well. So look how great she looks. Her husband gonna beat me, or whoever next to her. So good for you. I mean, you look awesome, and this is the way that you should look throughout your chemo, even if your chemo is, if you have metastatic disease and we're trying to slow the progress of the disease. Talk to your doctor. You shouldn't be nauseated. You shouldn't be throwing up. You shouldn't be not eating. You should do whatever you want to do, but always hope for the best and prepare for the worst. Get your duck in the row and make sure everything is set up for you no matter what the outcome is. Other symptoms patients don't talk about are depression. Come on, you're dealing with cancer. You've never dealt with anything this harsh all your life, even if you lost half your family. This is you. Don't let everybody around you gonna turn into a doctor and will tell you, if I were you and if I were you. Nobody is you. You are in your own shoes. Nobody is in your shoes. You're gonna do what's good for you. You're gonna do what's the best for you. When we're curing you with chemotherapy, I'm gonna chemo the living, you know what, out of you. So no whining, you're gonna get 6 months and call it a day. And we're hoping to cure your cancer or improve your chance of cure. If the disease had spread outside the colon, this is tough. The goal of treatment change. We're not curing it unless, what the surgeon said that sometimes it's small number of lesions and we can go and cut them out. But if it had spread, we can give you chemotherapy. The goal of chemotherapy, live longer with a good quality of life. And I insist on good quality of life. You want to go to church on Sunday. You want to go party. You want to celebrate somebody's birthday. You want to go on a cruise. Chemotherapy, I don't care if you come back to me and your CAT scan look beautiful and you've been in bed for 6 months. I don't want that. I want you to look and feel good Hope that we will slow the tumor as much as we can. We have a lot of chemo now that are active and not toxic. And we can improve your survival. People with colon cancer are living, metastatic colon cancer, living around 2 years. And when I say 2 years, it means some people lived less, a lot of people lived longer. So the best thing, and what we're trying to do with a day like this, is to prevent you from getting to that point. Get your colonoscopy early. It sucks, it's not fun, but you have to do it. We do a lot of other things for less benefit. This is very important. We catch the disease early, we can cure it, we can get you on your way, you can move on with life the way you want to live it. If you're just slacking, you don't want to do it, and I'm sure everybody this morning talked to you about what age to do it, when to do it, just listen to whatever they said. I was sleeping, so I don't know what they said. If you have family history, if you have somebody else in the family, go get the colonoscopy. I've had one against my will, and it wasn't as bad. I did not get anesthesia, which is, don't do that. But you can simply do it. Some things like this are why we do this. Somebody brought a very important question about insurance. If we start talking about insurance, it's going to be 2015 before we really go anywhere. Get insurance, talk to your whoever in your neighborhood. If you have a very active church group, there are a lot of people who do charity procedures. I'm not a big expert, but you can contact your primary care doctor and he can help you. We're not going to change healthcare this morning, but just get it, especially in patients, African American, Ashkenaz Jews, patients who are at a higher risk because of family history. You need to get that thing done. I'm sounding like Nancy Grace from... Okay. Questions?
Folks, if you're going to ask a question, raise your hand. That way I can know to circulate around the room. Anyone have a question? We have a very nice
Good.
microphone.
So, lunch is coming soon, so you don't have to. Okay, thank you.
Okay, we're at Lifelong Company Barbershop here in Charleston, South Carolina. And tell us what you're doing here with. Why is a barbershop and colorectal cancer, what do they have in common?
Well, it's information. You come to the barbershop and you learn about sports in the barbershop. You learn about what's going on in the community in the barbershop, and it's a good place to learn about health in the barbershop.
We have a lot of physicians that come to the shop, and we're always talking about so many of the health issues and colon cancer and being checked. They always mention that we have a history of colon cancer or any type of prostate cancer in your family that you need to get checked regularly. So, we're just talking on a more personal level. I told them that I'm really ready and looking forward to educating myself, one, and two, helping others and educating others about how important it is to get checked regularly and things like that. So.
What did you get tested?
Just health conscious. Family history.
After, hearing what was going on, and it's good to try to get it checked early. And I'm kind of a few years behind. I would like to know. It's time for me to do it. I will have it checked. I'm 53. 53? So you're planning? Yeah. No, I meant to do it back in my late 40s. I got a little busy and all that kind of thing. Yeah.
If you have a relationship with over 30,000 stylists, and they trust you, why not find creative ways to make them, get the information in the salons?
We have a chance to speak to the clients, to get the word out, where they can share it with other people. You come in contact with a lot of different people. You develop a relationship with a lot of your clients, and it gives you an opportunity to let them know, like she said, also to share, to stay up on things.
Does it bother you if the stylist talks to you about colorectal cancer?
No, because it may be something that I would need to get screened for down the line.
The information that I received today from Gerald is very helpful
because I can pass this information on to others, knowing that it's preventable if you catch it at an earlier stage.
So Gerald just told you this is the first time you heard it?
And that's the first time I've actually heard that it's preventable. But had I known this previously, I mean, it's very helpful to me, and I can spread the word to others.
What do you think are the factors that would prevent somebody from going in and getting screened? Anyone, I mean, men and women.
I think, and I know fear is a great factor in many of our lives, and fear will prevent us from going to the next step, getting screened. We're not sure what we'll find out. A lot of people have that belief or myth that it's better not knowing.
I just know that this is something that I have to do. When you reach the age of 50, we, as anyone, no matter what your diversity is, you need to have this check.
Spreading knowledge and increasing awareness is the beginning point in ending this deadly and extremely preventable disease. Statistics show that the mortality rate among African Americans is higher than any other race. We don't know why, but people like Gerald Footman are doing what they can do to spread the word in their community. In recognition of March being Colon Cancer Awareness Month, talk about it and raise consciousness where you can.
Okay, so now we'll proceed, and my next speaker is Dr. Sarah Hoff, Assistant Professor of Radiation Oncology here at Moffitt. She's been very helpful in assembling this entire panel from the Moffitt Cancer Center. We really appreciate it. And would you give us a few tidbits and things about radiation and how it can help us if we have cancer?
I'd like to thank Dr. McCoy for that kind introduction and really applaud all of you guys for getting up early and being here today. I think this is a monumental effort by the Crescent Foundation in partnership with the American Cancer Society. I think this is a fabulous thing, and I'm very excited you guys are all here today. Okay, I know I am one of the speakers standing between you guys and lunch, so I'm going to condense a 20-minute talk probably into about 10 minutes. And one of the most important things to me is that you understand what radiation is. So many people hear the word radiation and want to run the other way. And it's really not as scary as you think, and that's what I'm going to explain to you today. So first, what is radiation therapy? And what do doctors mean when they say you're going to have external radiation versus internal radiation? What does that mean? And what are the benefits of radiation? Why do we use radiation for patients who have colorectal cancer? And then finally, like Dr. Almana said, it's very important to talk to your doctor. Doctors know your particular case. We personalize the treatment information we give to that particular patient's case. And as he mentioned, so many patients came in and said, well, my aunt had this, and my aunt says I should do that, and my uncle says I should do that. Remember, they're not you. And so the team of doctors that have you know your particular case. And one of the benefits of everybody being here today, you see it takes a team. There's a team of doctors that are involved in cancer care, from the primary care physician who recommends the workup to the colonoscopy and anesthesia doctor like Dr. McCoy who takes care of the patients, and then to all of the physicians who do treatment. It takes a team. So, when we talk about radiation, there's two main types. There's external beam radiation and internal radiation. The fancy word for internal radiation, those young men can tell their teachers next week they learn the word brachytherapy. I guarantee you your teacher won't know what you're talking about if you go in and say you learned about brachytherapy. This is what a radiation machine looks like. The radiation is generated and comes out of the head of the machine. And the radiation is a beam of energy. So picture the biggest flashlight, the biggest, most powerful flashlight you could possibly imagine, and that's what radiation is. Except it's not a flashlight, it's a beam of energy that penetrates through the skin, goes into the part of the body we need to treat, and is capable of killing cancer cells. That's different than what we call internal radiation. Internal radiation is where we actually deal with things that are radioactive. My patients come in when they meet me, and they're often disappointed after they have treatment. I thought I was going to glow. No, there's no glowing involved. But this is an example of a man who got prostate radiation. So what is prostate radiation with seed implants? Seed implant is where the doctor places these little radioactive beads into the prostate. They stay there, they deliver their dose, and then they decay. A radioactive source decays with time until the activity goes away. So we have that type of internal radiation, and we also have a type of radiation that's a lot fancier than that one. We can put these little catheters into the area we want to treat, and then we can hook it up to a robot. And I think the young men over there, I might convince some of them to go into oncology after this talk today, because I bet they like computers, and wait till you see what we can do with computers. So what we can do with radiation, we have this little robot. And this little robot can house a radioactive source right inside. And what the doctor can do is they can take this catheter, which you see on the left-hand side of your screen, and they can put that catheter inside the rectum, and in some specific cases, we give radiation from the inside out. So that catheter is placed inside the patient's rectum. Then there's tubes that connect the catheter inside the patient to the robot. We turn on the robot, we deliver a treatment, and after about 10 minutes, we take the catheter out and the patient goes home. So there's all different types of things we can do nowadays for patients. At our cancer center, we have a team approach. We're a cancer hospital. We train young doctors in training, like Dr. Desireux mentioned. This is my colleague on the right, Dr. Sridhar. We have young residents, and we often are involved with a team approach to try to figure out what's best for that particular patient. So why do we do radiation, and why am I here today talking about colorectal cancer? Well, one of the things I can help patients with is help avoiding the bag. You heard Dr. Desiroux's talk this morning. She talked about the colostomy bag. Sometimes radiation, along with chemo, can help avoid the bag. We can shrink the cancer, and we can also help prevent the cancer from coming back where it started, in the pelvis. Now, many patients in the audience hear about all these different types of radiation. Just out of curiosity, is there anybody in the room today who watched the Good Morning America show this week with the rapid arc? Anybody see that presentation this week? Okay. I know a lot of my patients did, because I've gotten a lot of emails from people. Gosh, I was watching Good Morning America and I heard about this new cancer treatment that uses radiation. I'm here today to tell you that I don't want anybody to get focused on one type of radiation. There's many different types of radiation. I have enumerated them here. The most important thing for everybody to remember is when they're recommended to have radiation, they need to speak with the radiation doctor to figure out what's best for their particular case. Every day somebody comes into my office, I saw a billboard on Route 75. I want the CyberKnife. Or I saw a Good Morning America show. Remember that it's the team of doctors taking care of the patient who are going to know what's best for that particular patient. But to show you what we can do, we can shape the radiation so that all of this area here is blocked out. The radiation only comes out in the center. Now we have an even fancier way to shape the radiation beam. It's called intensity modulated radiation. We can be so precise, we can give a high dose sitting right next to an area that's getting a lower dose. And we're so precise that we know exactly where the tumor is. The pointer is not projecting, but you'll see a catheter in the rectum, and there's two little white dots, and I've identified them as markers. Dr. Vignesh, who spoke here this morning, can put markers next to the tumor in the rectum, so somebody like me knows exactly where the cancer is. Now, how do we know exactly where we're treating the patient? How do we make sure that we're in the same area? We now have the ability in 2010, when we deliver radiation, we can check the patient's position at 10 a.m. on Tuesday morning when they're on the table with how they were when I planned them 2 weeks ago. This is something new that's called image-guided radiation. So to give all of you guys in the audience who are thinking, well, I'm a little bit afraid, how do I know they're going to hit the right area? You don't have to worry about that anymore. We have the technology to be very, very precise. I'm going to advance the slide, so give me 1 minute. The other thing that you hear a lot about is tomotherapy. Tomotherapy is a type of radiation that looks like a CAT scan. The difference is, however, it rotates. And so I think even the people in the back row will see that the radiation is coming out and it's rotating around the patient. That gives us a lot of advantages sometimes to make sure that we focus the radiation where we want it and we minimize it where we don't want it. We now have the ability to be a lot more precise than we did 20 years ago, and like Dr. Almana said with chemo, it makes a difference. People are tolerating treatment better than they ever have before. And what about stereotactic? I mentioned the cyberknife. Has anybody seen the billboard in town, just out of curiosity? Okay, so a couple of people in the room. Patients think that cyberknife is for everybody. Again, certain circumstances, certain patients, not for everybody. And I mentioned the markers. Dr. Vignesh can place these little markers into the patient's rectum. This is an enlargement. The actual marker is a lot smaller than that, but somebody like Dr. Vignesh can place those markers right next to the tumor so somebody like me knows exactly where the cancer is. So I mentioned we're big at Moffitt in thinking about personalizing cancer care. What is the correct treatment for that particular patient? The team of doctors, that's what we think about with each patient we see. A lot of patients who get rectal cancer are simulated, that means set up the treatment, in a position where they lay on their tummy. They lay on their tummy in this device, and there's a hole, which is a cutout for their belly. And the advantage of that is we protect the belly from the radiation. Now, I know exactly where the cancer is in this case, and I think I could convince you that it's up in this area. You look up in that area, you see dark air, and next to it, you see what looks like some gray tissue. That's actually the cancer. And I want to point out that as the patient's breathing, the tumor in the rectum is moving. So in 2010, not only do I know where the cancer is, but I know how much it moves as the patient breathes. And we have a scan nowadays in medicine called a PET scan, and you can see here that there's the cancer. The same slide I just showed everybody, the cancer is there, and there's a cancer here. So we have improved ability to detect where patients' cancers are. And this helps me as the radiation doctor because then I can be very precise with where my radiation goes. And I can give a higher dose to the tumor and I can limit the dose to the normal tissue, which helps everybody in the audience if they ever have to go through this. This is an example of one of our patients. He's on the table on his belly, like I mentioned, and this is the big treatment machine. And that treatment machine is going to rotate around the patient and deliver external radiation. So a lot of people want to know, where's the future? I think one of the most exciting things about the future, there are researchers like the ones here who are thinking in the future we can predict patients' individual sensitivity to radiation. So what does that mean if you're the man in the back row? That means in the future, we're going to be able to take a sample of the tumor and we're going to be able to test it and we're going to know how sensitive that particular cancer is to radiation. So we're not there yet, but that's coming down the pike and it's very exciting. So just in summary today, I want to reinforce that there's many different types of radiation. It's not as scary as everybody in the audience probably thinks. We use it in more advanced stages of cancer for the benefits that I mentioned. And if we have to do radiation, it can help us avoid the bag and help us prevent the cancer from coming back. So thank you for your attention this morning.
Thanks again, Dr. Hoff. Our next speaker is Lorena Jefferson. She's an has a Master of Science in Psychology and Counseling, and she's with the Prestige Way of Life, and she's going to be talking to us a little bit about what she can do to help people who have cancer, a cancer diagnosis, and have to go through chemotherapy, radiation therapy, and surgical resection of tumors, how they deal with coping with the diagnosis and where they go from here. Thank you.
How you guys doing? Oh, you sound happy today. Well, I'm the last one, so you should be pretty happy. Yay. I don't blame you not one little bit. My name is Lorena Jefferson, and I created a company called Prestige Way of Life. Prestige Way of Life was born through actually adversity and different things that I've been through. It stands for people realizing every strength through intellect, guidance, and empowerment. The reason that Prestige was born was because of my life. Being a foster child early, lots of abuse, lots of neglect, mother murdered by a boyfriend. So I suffered loss very, very early. Never knew who my father was, so I never had those type of criteria or boundaries. Lots of adversity. And so through life I learned how to really deal with a lot of tragedy. I learned how to be a survivor. I learned how to find within myself, because I did not have adult boundaries on pretty much any level other than maybe a teacher or a guidance counselor here and there. So I had to find within myself a lot of strength, found out that I had so many abilities, that I was very agile, that I would determine my destiny. Out of the 6 of my siblings and I'm the only one that's not in prison. I'm the only one that's not on a controlled substance to this day. Not because I didn't want to, simply because I found very early that I had a tool that was called choice. And even through my adversity, it was up to me how I dealt with it. It was up to me how I processed it, and it was up to me to use it as a tool for my making and not for my breaking. So that's where Prestige comes from. Of course, the world told me you need to go get a degree in counseling and psychology. So although my life taught me how to help, I went and got the degree in psychology and counseling so that I would become a mental health counselor. These are some of the things I just told you about. These are my credentials. Ended up also with not just the master's in psychology and counseling, I also have a master's degree in business management and human resources. So that's that. These are some of the agencies that I work with. And this is a lot going on, so we're just going to scan through it a little bit because you guys are limited on time. But Prestige offers all of these type of services. One of the things that we're talking about today is the crisis intervention. I'm not going to read it. Pretty much, if you know what crisis intervention is of course once a person has been diagnosed or a person receives whatever message they receive, it's called trauma. You can go into a crisis mode, especially if it was unexpectedly. Not just unexpected, but especially depending on the level, the stage you're in, what you got to do, what the treatments are. All these things, when they're different for you, it causes distress. It can cause a lot of pressure. And with that pressure can come a lot of different symptoms. This is talking about the triggers. How do you know whether to refer somebody or whether not to refer somebody? These are some of the things that you can see. Not just for, you got to know that a person is in distress and needing crisis intervention. Crisis prevention, you'll hear us talk about both, but crisis prevention is really what we're going to do knowing that there's a chance. But once a person has been diagnosed with a disease or with a cancer, you really are in the intervention stage. A lot of the symptoms you'll see from depression, people may become suicidal. Some people may start talking kind of, out of their head a little bit. They may talk about doing things they never did before. They may start giving things away. You may start seeing them very negative. That's when we come in. Prestige is not just a therapeutic service. One of the things that I have realized in my life, and I've worked with families and children for 22 years now, one of the things that I realize is that everyone doesn't need a therapeutic service. Prestige is a support service. We do a lot of therapy for our children, for our teenagers, but I found that most adults have amazing coping skills. They're very agile. We all have tools that we can use, and a lot of times we just don't know how to use those tools. So what we do is we come in as a support service. We do a lot of what is called life coaching. Life coaching is this new term that everybody's saying now, and you have to be careful because a cook can call themselves a life coach, a janitor can call themselves a life coach, a high school student can call themselves a life coach. But one of the things you want to find in a life coach, because a life coach is really a support service. What they do is they help you to realize the tools that you have inside of you, your abilities, your natural abilities to be agile, your natural abilities to heal yourself psychologically, to make decisions. And through those decisions and through those positive energies that you're experiencing, the universe is already in place to heal you. And so that's what we do as a life coach. So you got to be careful when you're using a life coach. But Prestige, we actually have certified life coaches. We actually have people who have been in the therapeutic field, but who want to really just be able to support you. The Prestige way of life, these are some of the things that we do. As far as procedure, you call us, we give you some guidelines. I'm not going to go through this because we're running behind. But we give you a lot of guidelines about how to really handle the situation until we come in. When to refer, when you see a person contemplating suicide, you see that they're really not dealing with their issues. Some people use avoidance, some people use denial. You will see all types of things. The way you're going to know that a person is in crisis is you really have to know the person. You have to know a little bit about the character of the person, because you'll start to see shifts. You'll either see a shutdown, you'll see extra energy, you'll see less energy, you'll see negative energy, you'll see all types of things. So the only way to really know that a person needs an intervention is to know who that person is. And if you don't, even if you suspect it, you can talk to somebody who does know them or who knows how to evaluate appropriately. This is some other stuff about the crisis intervention. Okay. This is another program that I have with choices. Actually, that's my before and after picture. I was 300 pounds. And talking about crisis intervention and prevention, one of the things that happens not only during these times, but in any type of trauma, which I gave you guys a little brief description of my trauma. No, I didn't turn to drugs like my other brothers and sisters, but I turned to food. I still had a fix. You'll find a lot of people will start to get fixated on certain things if they're not ready to deal. In my denial stage, I used food as my fix. Coming out of my denial stage through healing, through crisis intervention, what I did was I had to go back and I had to deal with what my triggers were. What was it that I was in pain? Because I was creating these fatalistic means. I was actually trying to commit suicide, but through food. And what was happening was a lot of things I wasn't dealing with, and that's what you will see with people who go through these type of traumas. You may see them start gaining weight. You may see them lose weight. You may see them they may start throwing up, and they never threw up before. They may, become bulimic, or you may see anything. But this is a program that we use also with the crisis intervention and prevention, because it goes from one extreme to the other. But Choices Lifestyle Management Clinic is a clinic that I started after I lost 179 pounds. We have a mentorship program, and this is called Kitty Ventures. We work with crisis intervention and prevention with our teenagers through Kitty Ventures. Kitty Ventures is a trickle-down mentorship program. And what we do is we have created all these different avenues to deal with the different developmental stages. We still deal with the crisis intervention, but we also add the empowerment. We also add the intellect, which is the education, like what you guys are doing today, what the doctors are doing. They're here to educate us. Even with our education, unless we choose to act, it's not going to mean anything. Unless you use the education that you've received today and tell your parents or tell your brothers and tell your sisters or tell somebody else to tell somebody else, it's not going to be effective. But this is what we do through our mentorship for our teenagers. Kitty Ventures, these are all different things. We work with the parents, we work with churches, we work with organizations, we work with auxiliaries, we work with other professionals. We even work with doctors and lawyers and different people refer us to clients, to families that they're seeing in distress while they're working with them on whatever issue that they've been hired to work with them on. They bring us in as life coaches to help them with the distress, because if they're not getting the mental health part of it, you can treat the physical all you want to. It's just not going to be 100% holistic wellness. And that's what we want to do, is we want to add the key to bring the holistic part of it in. And we bring the mental health while you do whatever it is that you do. I've written 4 books. These are some books that I've written for parents. The Heart of the Matter is a book that talks kind of about what, it's not about wellness, but it is about wellness. It's about our mental health, and it's about the choices that we make. It's about how we can pinpoint specific characteristics in ourselves, how we can change it, how we can empower ourselves through intellect, through guidance, and through motivation. This is the last thing. I just moved to Tampa about 3 months ago. I have all these organizations in Orlando, but one of the things that I created was called the Tampa Wellness Association. When I came to Tampa and started visiting, I found that there's a lot of different entities, but I didn't see a full collaborative of holistic wellness. I know that the answer to everybody in their empowerment, so that they will live the life abundant that they're looking for, has to be not just in a piece of the wellness, but it needs to be addressed, the mind, body, and spirit. So the Tampa Wellness Association is bringing together a collaborative of all of our professionals who handle not just the mind, not just the body and the spirit, but bringing them together. And what we're doing as a wellness association is we are offering the platform for the professional. Everybody else is already working with their client, they're working with their patient, the patients are taken care of. But how do you know what doctor has the credentials? How do you give a doctor who knows exactly what they're doing quality care, the visibility? Well, what we're doing as an association is we're offering a platform for that professional to get the exposure they need into the community. And it's going to be a collaborative of people. And as far as joining the association, it will just give you more credentials on that level. The membership benefits are here, and I'll be at the table. These are how you can reach us. And I thank you. Is there money?
All right. I like that. So you go from the high-tech medical people talking, and we are people too, because we all are subjected to the same thing everyone else is. At this time, Brother Prince Sherwood, he's the president of the Tampa Alumni Chapter of Phi Beta Sigma Fraternity. I'm going to have you read the citation here.
Okay. These are certificates of appreciation on behalf of the Crescent Foundation in partnership with the Phi Beta Sigma Fraternity Incorporated Tampa Alumni Chapter. And it certifies that Catherine Allen participated in the Colorectal Community Education Symposium of the Sigma Wellness Health Initiative at H. Lee Moffitt Cancer Center to promote prevention, screening, early detection, and early treatment of colorectal cancer in an effort to reduce cancer, the cancer disparity in the African American community of Tampa Bay. Catherine Allen. And Dr. Henry O'Neill. All right, I'm going to, Dr. Khaldoon Almahana. Almahana. Thank you. And Dr. Sophie Desrault. Okay. And you might as well stand here because. And Dr. Sarhoff, thank you so much. We appreciate it. Lorraine Jefferson. Alfonso Simpson. Is he here? We'll hold on to that one. Dr. Dennis Laffer. We'll hold on to that. We'll make sure that he gets it.
Okay, this video is a segue into our second half of this presentation. Brother Terrence Howard, he's also the brother of Phi Beta Sigma Fraternity Incorporated.
She was the cornerstone of our family. She shaped me as an actor, as a musician, as a human being. So when my mother was diagnosed with colon cancer, it was like our whole family got cancer. And she died when she was only 56, so this is personal. And hopefully my heartbreak is your wake-up call. Colorectal cancer is the second leading cancer killer, but you can prevent this disease. Screening finds precancerous polyps so they can be removed before they turn into cancer. I've been screened. If you think that you're at an increased risk like I am, ask your doctor when to start screening. And if you're 50 or older, please get screened. I'd do anything to have my mother here. Please do all you can to stay around for yourself and for your family. Screening saves lives.
Again, we drive that same old story, get screened, see your doctor, get screened early. Detect it early, treat it early. Better prognosis, live longer, healthier, be with your family, grandchildren, friends. All right, we have a couple cancer survivors of colorectal cancer. I'd like to, I'm not sure how you want to do this. I think we'll go ladies first. Dr. Laffer, is that okay? I'd like to introduce Miss Anna Wilkinson and her husband.
Thank you so much. As he stated, my name is Anna Wilkinson, and just want to wish a good afternoon to everyone. I want to thank Mr. Phillips and the members of Phi Beta Sigma for putting on this event today, because it is so important that we get the word out. As you see by the empty seats, we have a lot of work to do ahead of us. But each one of you have a circle of influence that one of us may never be able to reach everyone. But if we all do our part by telling what we learned here today. And of course, Ms. Nikki Ross-Inda is the director of our Knowledge is Power here at Moffitt Cancer Center. But I want to go a step beyond that. Knowledge is power, but applied knowledge is wisdom. The things that you're going to hear, that you have heard already from all the doctors, I know a lot of it seems a little scary. I mean, sitting there seeing that stuff again myself, as a 3-year cancer survivor of stage 4 colon cancer. Just seeing some of those things again, thank you, to the glory of God, to the glory of God. Just seeing some of those things, it is a little disheartening. It's great for prevention if it wants, when you catch it on the early side, but what if you're already in that situation and you're already living through that? Some of those slides can be disheartening for you because they give all the statistics, they give all the time frames that they give you. Well, I'm here to tell you that that does not have to be your case if you are dealing with cancer of any type. The statistics are based on just numbers. Only God can say when you will expire, when you are going to leave this earth. And so I'm here to give you some encouragement, some hope, but I also want to tell you just a little bit about my journey with cancer. 2 things that are very important to me is my family and my faith. And I'm telling you, when you are walking through the valley of shadow of death, those things will become even dearer to you than you can imagine. And I was diagnosed with stage 4 colon cancer in July 2007. We were on a mission trip to Jamaica, and when we first touched down, after arriving, my legs began to swell. We kind of thought maybe it was something I ate, maybe it was the altitude of the plane, just a various litmus of all different things. Being in the past medical field, you start self-diagnosing yourself, so it could be this, it could be that, it could be this. So we just kind of went on. But by the end of the 7-day trip, I returned back to Tampa in a wheelchair and about 3 times the size that I had left with. So immediately upon touching down, we went straight over to the hospital to try to see what's going on. No one kind of knew. They couldn't find it. My blood work was all great. However, when they did an ultrasound, they found that one of my ovaries was the size of a volleyball and the other one was the size of a softball. So they knew surgery was imminent, that we were headed for surgery, and that particular hospital couldn't do what I needed, so they transferred me in the middle of the night to another hospital. Once we got there, I had a great team of doctors that wanted to slow things down. They knew they were headed for surgery, but they said, okay, let's see exactly what we're dealing with. So just based on what was going on in my body and some of the unanswered questions, they called over to Moffitt and asked if they can just have a consult with them and just have them ready for whatever it might be causing this. And so in surgery I go, all went well. And I'm telling you, my story kind of reads like one of those episodes on House, where the person goes in and they just do all these tests because they really don't know what they're looking for or what they're dealing with. And then all at once, that's the answer, and then the episode ends. But, so I may contact them. But anyway, after the surgery, it's just really the hand of God was on my life even then, even going through those things. Because what should have been 2 separate surgeries, I was able to have those surgeries back to back, which meant I didn't have to be opened up, closed, and then reopened up shortly after to have the second surgery, because all the doctors have gone, but they would testify that each doctor has limited scopes of what they can do inside the body. So once their part of the procedure is over, they have to turn you over to the next part. Well, one of the doctors that did a total hysterectomy on me to take care of all those bad organs said, okay, something caused this to grow like that. So we need to examine what is going on. So at that point, if you read some of the doctor's dictation, it kind of reads like a comic strip where they're examining all the different organs, and they take a number 3 clamp and they clamp this on the line, and then they go to the next organ. And so it wasn't until about 3 hours into the surgery that they actually started going through the colon and actually physically feeling the entire length of the colon. And so it was at the base of the colon that he found the lump. And at that time, he called up, said, hey, are you here on campus? The doctor said, yes. He said, hey, scrub in, I need you. And so I was able to have the colon removal done, 16 inches. And thankfully, they were able to fuse me back together where I did not have to wear a colostomy bag. And so every step of the way, you can see the handwork of the Lord just really protecting me, just outbeating all the statistics that in prognosis that people had said was going to happen to me. Thank God those things have not happened to me. And so just moving a little further in my testimony as far as the first round of cancer, really my husband and I, Gary, did not hear the word cancer until I was back in my room after the surgeries. They wake you up and, the doctor walks in with all these other doctors. But my focus was on the guy with the collar turned backwards. It's like, okay, why are they bringing a clergyman in here with me? And so that's when, they kind of was getting prepared for any scenario. But once they told us that cancer was found, they also told us that it was removed. So my husband and I, we really didn't have a big emotional experience. After all, they said they removed it. So we thought, okay, we're good. Things are better. God also placed my head nurse, who was able to share with me about she was a cancer survivor. So instantly, I was able to get my mind put at ease. Some of the things that I was going to be facing, she was able to sit on the side of the bed and now become a friend to me and not just a nurse, and actually tell us some detailed things that was going to happen. Moving forward, we went into the rounds of chemo, and of course, you know, the doctors here at Moffitt does a wonderful job of telling you all the information of side effects and the things that they're going to do to you and all the medicines that they're going to give you and all the prognosis and everything that should happen, shouldn't happen. And my husband is great with Googling everything, so of course he went on the internet and found out everything he thought he could find out about colorectal cancer and all the medicines they were going to give me and all the alternative medicines, meaning natural treatments that he could also provide to help with those side effects, to help my strength, my energy level, all those things. But I want to tell you as a survivor, no matter how much head knowledge you have of these things, you're still not ready, because once that cocktail is administered, you have to find a totally new normal. Nothing is ever the same once those drugs are administered into your body. They are life-saving, however they are life-altering as well. But my encouragement to you, I am now in my 3rd stage of chemo. We are doing well with the chemo. We have had every side effect that they said would happen has happened. We've had numerous side effects that they didn't tell me about that has happened. But I don't want to focus on all the negative and all that stuff that's going on. I want to give those of you that are dealing with cancer hope today, that you can look as good as I look today, you can feel as good as I feel, and that you can live while having cancer. But early detection is one of the greatest things that you can do. You can either get your colonoscopy early and prevent it, or you will have to have it on the back end. If I had known, I would have preferred to do it on the earlier end. However, I also want to encourage you that some of the time frames that they are giving you, you also have to be an active leader in your medical team. You are the most important person of that team. As all the doctors stated, that it takes a full team, and half of those people I've seen, they're all they are part of my medical team. And I praise God for them because He has used them to work through them in order to get me to where I am now. However, you as the patient, you know your body even better than they do. So you have to be an active part of your team. Something don't feel right, you need to speak up and say, it don't feel right. When you go into that doctor's office, they may be in a hurry, but you need to slow them down and say, listen, I need you to hear me. I need you to slow it down and just listen to me. And they will. You know, I've had several doctors run into the room and they're in a hurry, but end up spending 30 minutes with me because, no, I'm sorry, I understand you have more patients, but right now I'm number one as your patient. And so you have to be active. Follow the instructions, change your diet, make sure you exercise well. These are things that we know that we should do. We hear it all the time, but until we actually do it, it's not going to benefit us. So all this knowledge that you've heard here today from all of the doctors and that you will hear from some of the survivors, until you take that knowledge and you apply it to your own life, and it won't help you. And then, as I said before, that knowledge is power, but applied knowledge is wisdom. Grab someone in your circle of influence and take them along on the journey with you. Sometimes it's kind of difficult, especially about colorectal. I mean, we don't normally go around talking about our bowel movements. That's just not normal. I was diagnosed at age 39. I know the panel has told you that you don't even have to be checked until, if you're African American or multicultural, to 45. I had no symptoms that I thought of. I now know that not going to the bathroom every day was a symptom. But because, I mean, being a teenager or early 20s, you don't go around saying, did you go to the bathroom today? Did you have bowel movement? You just don't say those things. So knowing your body and that nice little slide they have now of what to look for, that's the first time I've ever saw that. That's wild. But knowing your own body and being able to help the doctors help you is going to be a great influence. One of the other things that I just wanted to kind of share with you is even though mine was stage 4, which they also say means it had already moved to other organs and that now the chances of it reoccurring is greater and higher, that does not have to be the case. Each one of you are an individual, and God has uniquely and wonderfully and fearfully made you. And so you are, you can change the face of stage 4 cancer. One of the deacons at my church is now saying I'm a stage 5. And I keep saying there is no stage 5. He says, yes, there is. There's life beyond stage 4, which means you're stage 5. And so once he said that, and that kind of sunk in a little bit, it's like, I'm the new face of stage 4 colorectal cancer. As my counterpart will tell you, there is life after the word cancer. However, you need to live while you're dealing with cancer. And through my faith and through my family and my friends, we received tremendous support for transportation, meals, just encouraging cards, prayers, and even financial support through our journey with this. My journey is not over at this time. And so I praise God for that, because through this journey, sometimes it's through the test that you actually get your testimony. I'm not saying, please hear me, I'm not saying that you have to have something major happen to you in order to have a testimony. But this happens to be my testimony, and I know God has a purpose for my life, and He has planned this thing, even that it may just be for me standing here today to speak to you. That could have been one of His plans. But thank you so much for allowing me to be here with you, sharing this journey with you. And I would like to leave just one scripture with you, and that's Ecclesiastes 3:3. For there's a time for everything, but at this time, it's a time for healing. Thank you.
Wow. Stage 4, stage 5. Impressive. Thank you very much, Ms. Wilkinson. Dr. Laffer, would you come join me here at the podium, please? Now, this gentleman is a physician, a colleague, and he's also a gastroenterologist. So he was the guy that would go and find the polyps and cancer and make recommendations. And he's a cancer survivor, and I'd like him to help and give some remarks as well, please.
First off, I'd like to thank everybody for the opportunity to speak here today. I have to make 2 confessions initially. One is, I went back to practice about 2.5 years ago, and I do use the Bristol stool form scale. And I was recently in England, and we were driving by Bristol, and I saw the sign, and I said, damn, I wish I had the card so I could take the picture with it. And the other thing which I have to confess, being a physician, is one of my major philosophies as a physician was, it's better to give than receive. Because I don't like going to doctors. I'm probably one of the worst patients you could have, because I don't like going to doctors. At age 50, when I received my AARP card, which I was very proud to get, I knew it was time to have my colonoscopy done. I had it lined up. The doctor who was supposed to be doing it had to have emergency heart surgery, so it got canceled. Then for a variety of reasons, I kept putting it off. Despite the fact at that time I had 2 young daughters, and one of my endoscopy techs, very lovely young lady, said, you know, you owe it to your daughters to have the test done because they're young and you don't want anything to happen to yourself. I said, you know, I'm not going to get colon cancer. I diagnose it. I'm not possibly going to get it. There's a theory among a lot of specialists that whatever specialty you're in, that's what you get. And over the years, I've seen that. Hematologists get leukemia. Neurologists had a stroke. Kidney doctor went into kidney failure. Cardiologist had a heart attack. I had irritable bowel syndrome. I thought, I'm fine. So around age 53, I had a cough that wouldn't go away. And finally, my wife said, you know, you should go get that checked out. So I was in solo practice at the time, went down the hall to a friend of mine, an internist. I said, I just want to have my lungs listened to see if I have pneumonia. The next thing I know, I'm getting a prostate exam and blood tests. And the blood test came back and showed I was anemic, meaning my blood count's low. And in average male, that implies most often you're losing blood chronically at a slow enough rate you can't see it with the eyeball. He blew it off, so there wasn't really much to worry about. I repeated it, a little bit higher, but still anemic. Repeated it again, a little bit lower, but this time I checked the iron level, and it was almost non-existent. And I said, I've got colon cancer. Now, I couldn't come out to my wife and say, you know, I have colon cancer. I said, you know, I have to have a colonoscopy done. And on the way to the hospital, I knew I had that, but I couldn't come out and say, I have cancer. I simply said, well, I hope they don't find anything that they have to operate on. So when I had the propofol administered, very experienced colorectal surgeon did the examination. I woke up, and some of the endoscopy people I worked with were in the room when I woke up, and they told me I have a colon cancer. Size-wise, 1.6 centimeters in diameter, extremely small for colon cancers. I have the advantage being a physician, especially being a gastroenterologist. I know the next steps that are going to occur. So I knew I'm looking at a colon resection, 6 weeks off of work, then I'll be back to work. So I scheduled at St. Joe's for an elective colon surgery, had a preoperative CT scan. I have the advantage also, I can go to the radiology department and look at the scan right away. Everybody else is told, oh, it takes 2 weeks to get the results back, but that's a myth. I had it that day, and I looked at it at the same time the radiologist saw it, and at the same time we saw in the left side of my liver there was a defect. I knew right away it was a metastasis. I tried to convince him for the next 15 minutes that it's really a benign finding, which generated 2 additional tests while I was there, and both of those confirmed it was a metastasis to the liver. So now I know that the scenario has drastically changed. I'd have to have chemotherapy for sure. I'm looking at liver resection, and I'm looking at much bigger operation. Ended up coming to Moffitt because they had the expertise at the time for a liver surgeon who could do the surgery. Had a complicated postoperative course, was in the hospital for 3 weeks, reoperated, went through chemotherapy, had another operation after I completed chemotherapy. Now, here I am at age 53. I've been a gastroenterologist since 31. Spent most of the time doing colonoscopies, telling people, you got to get the exam done because you may get colon cancer, or you may have polyps that have to be taken out, otherwise they may become malignant. And I didn't get my colonoscopy done at age 50. So a year after my diagnosis, I got approached with Colon Cancer Awareness Month, with Channel 10, I think it was, to do a story on colon cancer and colon cancer screening. And being a gastroenterologist whose goal in life is to tell people to get your colonoscopies done, and here I didn't get mine done, I was kind of reluctant to do that. But the rabbi at the synagogue I belonged to, he said, sometimes a little humiliation is good for you. So I went on air, I did an interview, I talked about colon cancer screening. All of it, all the relevant parts were edited out. And the caption of the story was, "Doctor learns to take his own advice." And if you did a Google search of my name, it's still out there. Then I agreed 2 years later to do it again. This is after I explained I didn't like it the first time. So they changed the caption, "Doctor fails to take his own advice and got cancer." So what I learned is the hard way is that when you allow certain things to happen. Now let me preface this. I have to throw in my role as a gastroenterologist because I don't necessarily agree with all the comments that were said. Colon cancer is highly preventable by colon cancer screening. And when you say colon cancer screening, it's a whole menu of choices from stool tests for microscopic traces of blood all the way to colonoscopy. But in the best of hands, in expert hands of colonoscopy, there is an inherent miss rate of about 10% due to the optics of the colonoscope, the anatomy of the colon. Then you factor in the skills of the endoscopist, the community, the quality of the prep, the time they're spending looking at the exam, these affect the accuracy and the detection rate. So you can't really say that colonoscopy or any screening test will prevent colon cancer. But what's been shown, it significantly decreases the risk of cancer developing, and it may allow you to detect cancer at an earlier stage rather than at stage 4 disease. So I learned that when you're diagnosed with a disease like this, you're branded with a scarlet letter on your forehead. In this case, it's a scarlet C. When I was at Moffitt for 3 weeks, 6 people called my office and said they heard I was dead. To this day, I hear from people, I'm dead. A year or so ago, I talked to a minority health conference for the ACS on colon cancer screening, and the director of the program, African-American gynecologist who works for the state, who I knew him in practice, when he was informed I was talking, he said, "Don't you know he passed away? Is this his son talking?" So your life is drastically changed, but what I realized even further is that the ramifications not only just affect you as the patient, because I had to go through surgery, developed a neuropathy from chemotherapy, got a great scar. I can't do those bathing suit commercials if I wanted to now. But it affects my family. I didn't find out too fairly recently that my oldest daughter at the time was in 9th grade, that it was really having a major emotional effect on her. I found out from some of her teachers years later that she'd go early to talk to them because she had to have somebody to confide in. So the moral of the story is that patients and their families have to be proactive in their health care. If you listen to different ACS talks, they'll say the most common reason for colon cancer screening, and that includes all the choices of colon cancer screening, not being performed is because the physician did not recommend it. But I think the flip side is nowadays with all the information out there, the patients have to demand it. Now, African American community screening starts at age 45, in part because the disease tends to be more aggressive, it tends to be more on the right side, it tends to be more advanced by the time of diagnosis. Now, nobody knows for sure, is that due to different genetics in the population? Is it due to problems with access to health care, socioeconomic problems? They can't afford the copay or the deductible. So in that circumstance, colonoscopy can't be the only test that's offered. Even stool testing for microscopic traces of blood has benefits. So the patient has to be proactive. When the dietitian talked about weight earlier, to get up and say you need to lose weight is very easy to say, but it's hard to do. I've become a big proponent of Weight Watchers. I'm not an official paid spokesman for them, but they have a very good track record. And I read recently that even an overweight, which is considered BMIs of 25 to 29.9, the risk of colon cancer and polyps are increased. Once you hit obesity at 30, the risk of colon cancer increases. So obese patients I screen more frequently. Smoking history too, alcohol history too. It's absolutely critical that people take better care of themselves. I have patients who come in and they say, my mother had polyps, and I'll say what kind of polyp they had. They tell me it's benign, no cancer. That's saying, what kind of car is it? It may be a precancerous polyp, but it may not. So if you have relatives that have polyps, siblings, parents, you got to find out what kind of polyps they are. And the other thing I can't stress, which I alluded to, is that once you finally make that decision to take that step to have a colonoscopy done, in my case, I hesitated because it was denial. I wasn't embarrassed about it. I wasn't afraid of the procedure. I just thought I couldn't have it done. Other people, it's embarrassing because of the position you're put in, the idea that some instruments be inserted into the rectum, people don't want to take a bowel preparation. Those are all really minor things. But the critical aspect of the whole test is that you have to go to somebody who has a lot of experience doing it. There are a variety of quality indicators which we'll go into that will describe how accurate or how likely that exam is a highly performed, reliable examination. Unfortunately, one of my colleagues brags about 3-minute colonoscopies from beginning to end, which is malpractice. So you have to be proactive. When you have a colonoscopy, ask them, how many have you done? How much time do you spend looking? And there's a concept called the adenoma detection rate. Adenomas are the precancerous polyps. Adenoma detection rate says in a person of average risk without a family history, first exam, age 50, this at least applies to the white population, 25% of males should have adenomas detected, 15% of females. If the rates are less than that, it means they're missing it. So I think that as the public gets more educated, and if you do a Google search looking at colon cancer and malpractice, you will see lawyer websites where they list all these quality indicators that the patient needs to ask about. Because you don't want, especially if you're average risk and going for the next 10 years, to have a suboptimal exam and leaving with a false sense of security when the examination wasn't done properly. So you have to ask the right questions. You have to ask the person who is going to do the exam those particular questions. You got to get the family history. You got to get the best bowel preparation you can do. Follow those instructions. But the important thing is you got to be really religious about getting the darn test done in the first place on time. There's enough what's called evidence-based medicine that supports every 10 years for average risk individuals and in the African American population starting at age 45. So I learned the hard way that being negligent to your own health has long-term effects. Had to close my solo practice down. I was not working for 3.5 years. Now work for a hospital-based group. Can't do procedures anymore because of neuropathy. And I want people to get the exams so they do not have to go through those steps I had to go through because they are totally life-altering. When I go to a GI conference every year and there's an expert on colon cancer and colon cancer screening, and the first year I saw him actually the month after I saw him, after my surgery, a month and a half, I came up to him and I said, you know, I have stage 4 colon cancer. And he gave me the look like, are you still alive? And every year I look for him and I come up to him and I tell him the same thing. After the second year, he stopped giving me the look. Now he tells me, make sure I come up to him next year to tell him. So for me, it's going to be 6 years on September 1st, but I don't take any, I appreciate that. That wasn't anything that was necessarily done on my part that I've lasted this long. I have to acknowledge that I put myself potentially in that particular position that I ended up in stage 4 disease in the first place when it may or may not have been preventable if I'd done it earlier. Thank you very much, and have your colonoscopies done.
Okay, making healthy lifestyle choices, getting past myths and fears about going to the doctor, and having an annual physical examination with your primary care physician and get some kind of screening test, whether it's fecal occult blood testing, colonoscopy, and several other tests that we've discussed today. Just get them done so we can start preventing this and defeating this disease. If you don't have a health care plan, try to find one that is suitable for your budget, because out-of-pocket expenses can be costly for doctors, office fees, individual medical tests, procedures, surgery, hospital stays, and again, not just for colorectal cancer, but for all medical conditions. I'd like to thank the panelists for taking time out of their busy schedules to come out and giving all of us information that we can use in our daily choices of health styles and going to the doctor. And since many of you have to leave due to professional obligations, they've already gone. Everybody else is at the end of the program here. I'd like to also thank the Symposium Committee. These guys work with me on this program. They're listed on the program. Brother Zanny Mount, who's not here. He had to attend the funeral of one of our fallen brothers, chapter brothers, Brother Philip Harris, who was the coordinator for this event. Brother Prince Sherwood, the president of the Phi Beta Sigma Fraternity Tampa alumni. Brother Jamal Wilberg, the second vice president of the chapter. Eric White, he's listed as a graphic designer of the program and promotional materials. He's responsible for this beautiful banner and our fraternity banner out front and the Sigma Wellness banners out front. But he's also a brother of Phi Beta Sigma Fraternity Tampa alumni. He just thought it was just too much to put on here. Gregory Carroll, Brother Gregory Carroll, thank you very much. Dwayne James and Eric Wilson. I'd like to also especially thank Dr. Green, who I think he's gone for the day. Dr. Deanna Wathington, who probably couldn't make it, but she helped facilitate some of this event. She's put me in touch with Dr. Cheryl Rodriguez and the Institute of Black Life. Thank you, Dr. Rodriguez, for your help. And I can't give enough thanks to Erica Harris, who's facilitated our liaison with Moffitt and getting this event to work the way it is. And without the American Cancer Society doing whatever they do every day for the last several years, it's been what, since 1920 something? Yeah, 1920 something. They do tremendous work in all cancers, breast cancer, colorectal cancer, prostate cancer. They do Relay for Life every year, which the chapter is very active in every year. We were the third, ranked as, I think, the third highest chapter in the fraternity as far as collection of donations for that event. But without the American Cancer Society, this event would have never taken place. Thank you so much, and we appreciate being able to do this for the community.
I want to thank the Ryan Sims Foundation. This is one of our partners. We receive tremendous amount of support from the Ryan Sims Foundation. Many of you have seen the young men that were standing around here. This is our youth mentoring group. It's called the Sigma Betas. These are a tremendous group of young men. The fraternity takes their time to invest in our future, and by reaching back and making sure that we provide as much guidance and as much positive role model as possible, these young men grow up and to be the future doctors and lawyers and and the professionals that you'll see around you. As a president of the fraternity, I also want to thank my fellow fraternity members of Phi Beta Sigma. If you can please stand. Many of these individuals are either on the board of the Crescent Foundation, or they provide the engine that allows programs like this to take place. We don't have a staff. We're a completely volunteer organization, and without the support of these individuals, we can't move these programs forward. I also like to thank Charles Morse, who is also my fraternity brother. He's providing the videography here. And for those of you watching online, this is made possible through designedbyfrance.com. Just wanted to get that plug in there. Thank you. We're going to have programs. Oh, and for all of you who are looking online and for all of you in blue and white, I apologize. I'm going to put you on the spot, Charles. Charles E. Morse. And for those of you who are watching online who are fraternity brothers, it sink in a second. Yes, he is the grandson of our founder, Leonard F. Morse, and he's also a Sigma. So, and Brother Hankerson Photography, cannot forget the outstanding work that Jermaine Hankerson is doing. Visit him online at hankersonphotography.com. his ability to capture images and still life is beyond measure. So visit him online, hankersonphotography.com. And that's pretty much it. We'd like to bring this program to a close. Thank you so much for coming out on behalf of the Crescent Foundation and the Tampa Alumni Phi Beta Sigma. Thank you.